Hello, good evening, everyone. It's a great pleasure to welcome you all for the day two of second changing outcomes in sphere of gastrointestinal cancer. It's a great pleasure to welcome Dr. Naresh Somani, Director Oncology and Head of the Department Medical Oncology, SCG Cancer Center, and Director at Somani Hospital, Jaipur. Good evening, Dr. Somani. The floor is yours for your welcome and introduction and setting the context, please. Over to you, sir.
Thanks, Mr. Tarun from the Horizon, and good evening to all. I'm thankful to the organizing team, especially Dr. P. Dattatre, to give me this opportunity. This 2 days meeting, as we all know, is under the aegis of the SOMAX Research and Health Organization, a research organization in the field of the clinical meetings, webinars, and so on. So, without taking much of our time, for the today's first session, which is regarding the molecular tumor board in the field of the GI. For that, I invite the moderator, Dr. Bhuvan Chuk, who is consultant medical oncologist at the Max Hospital, Saket and Gurugram, Delhi. He will be moderating this session, which is, I believe, is very important in the present era, in the present context. And for that, we have the great panelist with us, Dr. Bharat Vaswani from Hyderabad, medical oncologist from the Yasoda Hospital. Dr. Rahul Sood is consultant medical oncologist at the Command Hospital, Bengaluru. And Dr. Viraj Lavanya, consultant medical oncologist, GI services, HCG Cancer Center, Ahmedabad. Dr. Amit Verma, again the consultant molecular oncology and cancer genetics in charge at the Max Hospital, New Delhi. And over to you, Dr. Bhuvan Chuk. Thank you.
Thank you, sir. Thank you so much. And I'd like to thank Viraj for this opportunity. And he got in touch with me. And I think this is something which he had done in the past. And I think it has been a great learning for me. Can we have the slides, please? And I guess all my panelists are here, and I'll like to dig into it to begin with. Tech team, can you please project the slides?
Sure, we'll do that, sir.
Can you do in the presentation mode? Yes, sir. So we're going to start discussing the cases. And so try to limit the cases to 3. I think we should be able to wrap it up in 30-35 minutes. But then without taking much of the time, let's begin. So case 1, can I have the next slide? So it's a 61. She's a 61-year-old female. She is a retired IFS officer. Just to say that she has a government support when it comes to the buying the medicines, and she is also a known case of type 2 diabetes. She had presented to us with the jaundice along with fever and chills, basically, and with the features of cholangitis. She is admitted in gastroenterology. Next slide, please. So workup, MRI abdomen was done, and it was suggestive of a lesion in the. Can I have the next slide? A lesion in the head of the pancreas. You can all see the lesion. It's a large lesion in the head of the pancreas, and it was engulfing the arteries, and it was unresectable to begin with. And she underwent metallic stenting, and once she underwent the metallic stenting, her bilirubin had come down, and she was started on antibiotics. Next slide, please. So again, you can see the lesion. It is a pretty big lesion in the head of the pancreas. It is encasing the vessels around, and it is unresectable. Next slide. So the workup was done. USFNA was shown. USFNA was done. It showed a peribiliary mass, which was positive for malignant cells. Histopathology was done. It was suggestive of squamous cell carcinoma with the possibility of squamous component of adenosquamous cell carcinoma. ERCP, metallic stenting done, gradual reduction in bilirubin levels. The fever settled, and the patient was transferred to oncology services. Next slide, please. PET scan was done, and again was consistent with a hypermetabolic, lightly mitotic lesion in the retroperitoneum involving the head of the pancreas. And there was upstream IHBR, which had obviously started to settle. And there was a marginal pancreatic duct prominence. Next slide, please. That's the PET scan, which we all can see. And it looks like a locally advanced lesion. And obviously, there's no other metastatic site in the body. And next slide. So a tumor board was done. It was an inoperable lesion, and she was started on a standard of chemotherapy. The options were to start her on FOLFIRINOX versus gemcitabine nab-paclitaxel, thinking that she had she had a squamous component. I think the literature also supported that we started on gemcitabine nab-paclitaxel, and it was an atypical case. We sent the cell block, was sent for NGS for foundation. Next slide, please. So this was the response after 3 cycles of gemcitabine nab-paclitaxel. The tumor has started to respond, but it was still there. You can see the metallic stent in place, and there's a partial response to the tumor. Next slide. So again, PET scan was done after 3 cycles, and it had shown interval decrease in size. And FDG evaluative of the previous noted mass involving the head of the pancreas was still there, and there is a interval appearance of mild soft tissue stranding around the lesion. Next slide, please. This is when we received the foundation report, and I would like to call probably Dr. Rahul Sood, if you can look at the lesion, look at the findings. I think it was something which came as a surprise to us. And what would your take on it be when you have such a patient who's atypical, who has a pancreatic adenosquamous, and with this molecular report, what would your take would be?
Right. So we are dealing with an unresectable pancreatic tumor adenosquamous who has received, I believe, total now 6 cycles of chemotherapy.
Patient had received 3 cycles of gemcitabine nab-paclitaxel.
Right. So three cycles, and post that there is a progression of the tumor.
No, there's a responsive disease.
Okay, there is a responsive disease. Correct. So in the meantime, you got the foundation report, which shows that you've got an MLH1, MLL2, and MSH3. That is what you get here.
So basically, yeah. So the microsatellite status, which was a MSI high lesion, and it was
it's a MSI high tumor. That is what you get here, and since the patient has had a response, I would look at this report, but I'll not probably action it immediately, but keep things in mind. And since there is a response, so I would continue the same chemotherapy for another 3 more cycles.
Dr. Viraj, what would your take would be? Would you agree with Dr. Rahul's opinion, or?
First of all, excellent case, Bhuvan. Very nice. Pancreatic adenosquamous. I wonder, is it actually pancreatic or extrahepatic cholangio? Which is going into pancreatic head. But nevertheless, this is a classic MSI high genomic report of anyone who has, lots of multiple mutations, high TMB associated with MSI high. I would definitely be jumping towards checkpoint blockade. We know chemotherapy will have a short-lived response. If this was a negative report, or I was thinking that nothing would come, you won't be able to target this, then I would agree with Dr. Rahul that continue chemo and then perhaps consolidate with radiation, since it is just loco-regional. But with this finding, I would be very, very tempted to go checkpoint blockade.
So what your intent would be? Would you want to, give it a palliative intent? Would you want to convert it to a curative intent? That's where
we know, right? MSI high TMB. These are the patients who potentially can quote unquote get cured with checkpoint blockade. So yeah, or at least have a very, very long-term durable response. So of course, not to convert them for operation, but if this patient responds to checkpoint blockade, this patient would go on. Like I have a gallbladder patient, similar, 4 years out, MSI high, Pembro. So you don't need to do anything, right?
So, Dr. Amit, your take on it?
One very interesting case, and I'm tempted to use immunotherapy upfront along with the chemotherapy. The intent definitely would be to control the disease. We know it's a poor prognostic disease actually. And if we are able to make it resectable, very good. We should attempt that. Important observation in this report, I wanted to highlight that patients do have MLH1 loss, whether it is a somatic or whether it is germinal, which need to investigate further. That is one. It probably could be a possibility of Lynch, which we have obligations to inform the family as well. But on the other hand, the patient also have CDK N2AB loss and MTAP loss. These two biomarkers, when they are lost, it reflects a 9p deletion, which is a significant deletion and reflects cold tumor microenvironment. Over here, the chances that immunotherapy or immunomonotherapy will work will be very less. So we should not 100% bank upon immunotherapy alone. It has to be combined with other modalities to make the tumor hot and to expect better responses. So otherwise, other biomarkers like PBRM1 also points out towards the better response to immunotherapy, which is again a favorable thing for us. And but same time, it is a very unique histology, rare histology. We are not finding the classical KRAS mutation. So the driver seems to be NF1 because we see some two loss of function here, again activating the RAS-MAP kinase pathway, which is normally seen in the pancreatic cancer. So having said that, I would jump upon IO upfront. You may see a very good response, but again, we should be skeptical, as I told, that the microenvironment is cold in this particular case.
Kind of. Do we have Dr. Bharat also? Has he joined in? Because I couldn't. I think there was a.
Bhuvan, Dr. Deborah had a comment to make in a chat. She suggested that MSI high is not as high as she would like, and again, she would be skeptical. Dr. Deborah, can you elaborate on that, please?
Sure. This is a really interesting case, and thank you for sharing it. I would be concerned that the MSI high phenotype that responds very well to immunotherapy, such as your patient that you described 4 years out, these are the patients who have lots and lots and lots of mutations. And a tumor mutational burden of 13 is not as high as I would have expected with the MSI high phenotype that responds well to immunotherapy. And of course, thinking about the toxicity and financial toxicity of treatment, she's had a response to her first-line chemotherapy. She has locally advanced disease. So I would actually think about giving radiation to this tumor, and perhaps we'll be sparing her some toxicity and financial toxicity later on down the line. So I would be more enthusiastic to think about radiation if this tumor has shrunk to a size where it can be treated with SBRT, for example, and perhaps save other systemic therapy to later on when it's being used more palliatively if she progresses.
I think that's a fair way to look at it. But so I do agree with you that the TMB doesn't look as high of suggestive MSI, and it is when I looked at it also, I was kind of disappointed looking at the TMB. But then as she had a locally advanced tumor, and the surgery was always a possibility if the tumor reduction happened to a significant degree. So do we have Dr. Bharat, or we can move ahead?
Bharat will be joining little later.
Fair enough. So can we have the next slide, please? So what we did was we added pembrolizumab Keytruda to her because of the MSI high status, and she obviously, as I told you, she is a retired IFS officer. In India, there is a financial support by the central government when you have when you are using immunotherapy, especially. So she was getting it obviously free of cost to herself, but yes, there was somebody paying the cost for it. Next slide, please. She had an amazing response. The tumor almost disappeared. It was we were barely able to see the report, barely able to see the tumor. Next slide, please. So yeah, if you can see that, by the time, I think we gave her 6 doses of Keytruda, I think, if I'm not wrong, we gave her 3, there was some response, and then we gave her 3 more. There was hardly any tumor seen. Next slide, please. Yeah, just go back to the slide before. So what we did was, when we gave her 6 doses of Keytruda, she had a tumor which had completely responded, and she was offered a surgery. And when we had a tumor board again, and I think the GI surgeon agreed to give it a try for the surgery. Yes, it was a difficult surgery, but then she being a foreign services officer, she took an opinion from Australia. I think her daughter was there, and she took an opinion from US also. And I think US surgeons did agree that the surgery should be given a try, but Australians, they were not in favor of surgery. I think she, after another 3 cycles, she underwent radiotherapy. She underwent SBRT for the entire thing. And she underwent SBRT somewhere in January or February 2021. And I think the surgeon was not the Indian surgeon. The primary follow-up surgeon also had some reservation taking it out. But then I had changed the institute by then, and we had come to Max, and we offered to take her out, take the tumor out, but couldn't. I think so. She continued after the radiation. She continued on immunotherapy for a while, and I think it gave her a disease-free survival of somewhere around 10 months. And last I saw her was in October last year, when she had peritoneal dissemination. So I think that was about it. So I just wanted to ask if Professor Miller or Dr. MS or Dr. Viraj, if you could tell me what's your usual. So have you treated somebody who has had a MSI high, and how many doses of immunotherapy generally do they progress after? Do you have an experience with that?
Yeah, Bhuvan, you asked me.
Yes. So have you treated MSI high? How frequent?
So
how long does it take for them to respond to stop responding to immunotherapy?
I am very surprised with the rapidity which this tumor responded to checkpoint blockade. I would have expected a very, very durable response, or even after stopping after 6 doses. So I have a patient 2.5 years out, just after 4 doses. That is MSI high cholangio, just 4 doses, because that patient had grade 4 colitis. So I couldn't repeat it. But 2.5 years out, she's still in CR. I have another colorectal patient, took just 6 months because of cost. And again, she's 2 years out, no disease, no relapse. So very strange that this patient has a relapse. But yes, I tend to continue at least till 1 year, not standard 2 years, what is recommended, just because of the cost. But this lady does not have a cost issue. I think we could have continued for longer term.
So we did conduce that. I think we differed in the way we wanted to approach her locally. I think I was more in favor of surgery, and she was more in favor of radiation. I think that's where I think that the thing fell apart. And I think coming back to the point of DFS, I think it gave her a DFS of around a year. I don't think it gave her more than that. So I think that was, so once you've had a local control of the disease, my approach was that let's take care of it rather than let it be around for a while.
But you should re-challenge this lady, so with CTLA,
I think we should do that.
Nevo EP, fantastic case.
Anyway, let's move to the next case, please. So again, she is a 53-year-old female who is because she has had a long history, we'll not start from the beginning. So she is a metastatic adenocarcinoma rectosigmoid, and she had liver disease to begin with. It was a huge liver burden, and there was some suspicious internal memory nodes. So she underwent because she had almost an obstruction, and so we had started her with a staging lab followed by ultra low LAR, because we thought she'll end up with an obstruction during the treatment. And descending colostomy was done, and excision biopsy of the liver lesion was done. And this was in July 2020, almost 1.5 years out. So obviously the molecular markers were sent. It was a KRAS, NRAS, BRAF wild type. It was a MMR intact and HER7 negative case. So we started her on Folfox plus panitumumab, the Vectibix, in July 2020. And the patient underwent and for a liver-directed therapy for the liver lesion, but because of the suspicious internal memory nodes, we thought let's observe it for a while. Next slide, please. So while I think she was receiving her 8th or 9th cycle, she had a major 5FU associated encephalopathy. Always thought we would want to do a liver-directed therapy. We looked at the internal memory node again because we wanted to know if it is metastatic or not, and it was consistent with metastatic lesion. So because it was consistent with metastatic lesion, we thought it's better to continue with the I think thing which was there.
So I'm just trying to see, is this liquid or biopsy?
No, this is a solid biopsy.
Okay, so you repeated the biopsy.
So we did a biopsy, and I think it was we were able to repeat the biopsy. I don't think
After
that was an issue.
KPD plus BEV.
After somewhere between the K-Pyri Bev.
Okay. Yeah. So I would not treat based on TMB of 10. Wild type status. Oh, EGFR amplification is there. Okay. Yeah, so perhaps that is the reason for the resistance to anti-EGFR. Yeah, so I wouldn't APC and EGFR. No, so I wouldn't be able to target this. So,
Fair enough. I think I was stuck with this report in my hand, and I was like, "Oh my God, what should I do now?" Always did it. So, Dr. Amit, if you can come in and possibly help us out, what would you see in this report, and how would you help us take it from here?
EGFR amplification or EGFR overexpression is a norm for most of the GI cancers, especially the colon cancer. So for me, that is not unusual. We should not get swayed based on that and continue anti-EGFR therapy. If you see the fold amplification, it is only 5 times, 4.99x. So that is also not that very high, but it tells us, yes, that the patient will respond to anti-EGFR therapy. So continuing anti-EGFR therapy and changing the chemotherapy backbone is acceptable to me. And I'm not able to find any resistance mechanism which is downstream of the EGFR. So I'm expecting still a response on the anti-EGFR therapy.
Fair enough. Dr. Rahul Sood, if you're still there.
Yeah, I'm still definitely there. So I had a query that when the lymph node was taken out from the mammary, lymph node was taken out, was the KRAS, NRAS, BRAF repeated? Because you continued on the anti-EGFR, that is, you changed from Vectibix to panitumumab.
No,
was it
the same? Vectibix is panitumumab, right?
Yeah. So was on the lymph node, was the KRAS, NRAS, BRAF repeated?
No, it was not repeated. It was done on the primary thing.
Oh, on the primary itself. So what I feel is that patient has already received anti-EGFR.
We did the biopsy.
Okay.
We thought I could preempt that, if this fails, I need to have a next line in place, basically.
Right. So I think the patient has had his share of anti-EGFR as well as anti-VEGF. I think the way to go forward is with regorafenib at this point. That is my take.
Fair enough. Can we have the next slide, please?
Bhuvan, can I have
Yeah.
Dr. Dev's opinion on this, that EGFR amplification, we have enough evidence in colorectal cancer that it is resistance mechanism of anti-EGFR. Dr. Deborah, what's your thought on that?
I think this is a tricky one. I agree that TMB of 10 would not make me excited to use immunotherapy. Regarding the resistance mechanisms of amplification, I guess we have a little data, but not a huge amount of prospective data. So the main issue I think we've discussed is that she's already had 2 lines of chemotherapy with the anti-EGFR targeted therapy and is still progressing. So I'm not sure there's much further benefit to be gained. So unfortunately, we're still back to other third-line treatments, Lonsurf, regorafenib.
So I think let's take it from there. Because there was a division of opinion, and the options were regorafenib versus EGFR, and there was EGFR amplification. So we started on Liporil plus cetuximab, and we wanted to change the chemotherapy backbone. So Liporil plus cetuximab was given for, I think, 2 months. She had a poor tolerance to Liporil, and there was a CEA which was progressively rising. So we did a PET CT, and there was no response to cetuximab, and it was a progressive disease. And I think from there, as Dr. Deborah also said, I was also tempted to use Keytruda there because of the TMB high status, but then the patient was unwilling at that time. And I think in October 2021, she was started on regorafenib, and we gave it for around 3.5 months. There was not much of response there also. And now we have started on Keytruda, I think January 1st. So she just received the second Keytruda around a week back. I think we are trying to see the response there. So this was the second case. If somebody has a comment to make, I think this will be the time.
How was the performance of the patient? Patient has received almost 5 or 6 lines of therapy. I'm very surprised the performance of the patient after an initial hit of 5-FU based encephalitis, and she's gone through so many and things, and now either the disease biology is very good or the performance status is excellent for you to start on Keytruda.
No, so I'll tell you the most surprising thing. She used to fly in every 2 weeks from Nepal to get her treatment done. So you can tell me that she hasn't maintained performance status. So she's a wife of some big shot in Nepal. So they used to fly in every 2 weeks.
I think a very decent biology disease that we're dealing with. So that's all I think I can say. Right.
So I think we have time for one more case. So let's move on. This is also a very interesting case. Next slide, please. So again, sorry, all my cases are females. There's nothing sexist about it. It's just that they were the ones who I'm stuck with. So a 52-year-old female, this I am still dealing with it, and I really would want to take the panel opinion because I still have to advise her treatment. But she's a 52-year-old female, and she was detected to have CHGB, underwent radical cholecystectomy in October 2019. So around 1.5 year, 2 years, 1.5 year, and 2.5 years, sorry. So she had a T3N1 disease. We started her on gemcitabine cisplatin. So November 2019, we started her, and March 2020 is where she finished her gemcis. She was planned for CTRT because of a node positive status. There was a plus minus evidence, but we thought let's err towards the higher side. But it was delayed because I think March 2020 is when we were all hit with COVID, and I think she couldn't undergo radiation then. And I think she underwent a review PET scan some 3-4 months down the line, and it was suggestive of a nodal recurrence in the paraortic nodes. So she had a DFI of around 5 months. Next slide, please. So she underwent CTRT then, and for that she underwent a standard CTRT with capecitabine, and it finished on October 2021. A reassessment done in 2021 Jan. So this is 2020, sorry. So reassessment done in Jan 2021 was no active disease. June 2021 she had onset of back pain, and she underwent September 2021 she underwent a reassessment in which there was an active disease in the paraortic nodes, and there was a filling defect seen in the pulmonary arteries, I guess. So DFI of around October 2020 to June 2021. The biopsy from the para-aortic lesion was done, and it was metastatic adenocarcinoma. CA19.9 was CA19.9 positive, and CA99.9 was increasing. She was planned for the FOLFOX-based therapy. Next slide, please. Yes. So I think can we have the can we have the next slide, please? If you have, I think 2-3 slides will be there. I think there's a slide missing. Next, can you just see me? Can you just one second. Sorry, I think I forgot to attach a slide, but then can you go back to the case history slide? Go back, please. Go back. Yeah. So after this, I think, no, just the FOLFOX one, the last, after this. Can you come to the next slide, please? Yeah. So she was planned for the FOLFOX-based therapy, and she was HER2 positive. We got her markers done, and she was HER2 positive. And with this HER2 positivity, she was started on FOLFOX plus trastuzumab 2 weekly. And I think we gave her 6 doses of FOLFOX plus trastuzumab, and her CA19.9 rose from 720 to 8,000. And with this increase in 720, CA19.9, 720 to 8,000, and kind of reassessment at the 3 months, she had a progressive disease. Now with the FOLFOX trastuzumab done, progressive disease, no new disease, but a progressive disease was there. There was a significant increase in the nodal burden and the FDG activities. We started around FOLFIRI plus trastuzumab, and we also did a biopsy, repeat biopsy, and sent it for NGS. Now the report which is going to come to you is after, it's the post-progression, post-FOLFOX plus trastuzumab progression report which is going to come to you. Next slide, please. So this is what he's looking at. Dr. Raul, do you want to take this to begin with?
Yeah. So I think she's progressed on 3 lines, like you mentioned, if I'm correct.
GemCis and FOLFOX. So basically, she has progressed after GemCis and FOLFOX trastuzumab, 2 lines.
You also gave FOLFIRI also?
She's continuing on FOLFIRI plus trastuzumab, but this report is after the FOLFOX trastuzumab.
Okay, sir. So I'll continue the patient on FOLFIRI with trastuzumab. That is an option, and I would definitely, the patient is having an expression of PD-L1. The data in gallbladder though is lacking. TMB is low. This one option is that. The other is the presence of your SNV in TP53 is mentioned about olaparib and or carboplatin. So, but I think the only thing that I feel is that the PD-L1 is positive.
So let me show you the PD-L1 report. Can you go to the next slide and show the marker is, the expression is not that high. I think CPS is 2 to 3%. Can you come back? Next slide, please.
Okay.
Next slide, please. Next. Yeah, so I think this is, the CPS score is 2 to 4%, the TPS is 0 to 1%. So yes, there is a PD-L1 expression, but then the CPS score is not that great. It's a 2 to 4% CPS score.
Yeah, so I'll quote what Dr. Viraj taught us yesterday regarding CPS and upper GI cancers. So I think it's not that significant that is there, but yeah, I don't know whether immunotherapy will work in this, but I definitely would like to continue the FOLFIRI with trastuzumab. Another option in such a patient is probably lapatinib with capecitabine in this patient. Immunotherapy in this patient, I don't think so. I with this report, I will not. And also the data is not that great in gallbladder.
Right. So let's go back another one or two slides, because there's something interesting which I want to bring about. Let's go back to the let's go back one slide, please.
HER2 is negative to 1 in this.
Yeah, so let's go back one more slide. So now, if you look at the note, what is surprising is that they said that we have detected a copy number gain of 5 in HER2 gene. However, the cutoff for reporting our amplification is 6. So this requires a confirmation by FISH or MLP. And I'm dumbstruck, because she was HER2 positive on IHC, and what I would want to ask the panel or Dr. Amit is, can this aberration happen in a ERBB2 expression? So generally what we see is, we generally see a weak positive is what it reports or repeats as. And what I gain is, so if it's a 5 number gain of 5 and it doesn't qualify the criteria, should we be continuing the trastuzumab? And what I'm surprised is, somebody who has a trastuzumab positive, somebody who has a HER2 positivity, they generally respond well to trastuzumab at least for 6, 8, 10 months, and then that's when they start progressing. And so that's where it is. So Dr. Amit, I would like to take your take on it.
So had it been a foundation report, they would have labeled it as a ERBB2 amplification. Their cutoff criteria is 5. On the other hand, different labs have their own cutoff criteria. So if you have the bottom line expression to be high, you should be confident that the approach of anti-HER2/neu is appropriate. So you can be confident that you can expect response. But if the amplification is higher or the expression is higher, definitely the response rate may be better. But I'm very confident that yes, this is an appropriate case for anti-HER2 therapy, even there is a discrepancy in the IHC and the gene amplification.
So what you're saying is, this is not an appropriate case, is what you're saying, right?
This is an appropriate case, an eligible case for anti-HER2. This
so
discrepancy is based on the this discrepancy is based on the inter-lab cutoff criteria. That's what I'm saying. Normal cutoff criteria for amplification is 6, but foundation have mentioned that for the ERBB2, the cutoff criteria is 5.
My apologies, sir. You are just left with 4 minutes to conclude the panel discussion. Thank you.
That's okay. This is the last case. So can we go to the one? Can we go back? Can we go back one slide? So anything in this, Dr. Verma and Dr. Miller, if you could look at it and tell me, help us, because this lady is going to be asking me the next, and I'm actively searching for the next treatment in her. Dr. Verma, Dr. Amit, can you suggest the next line, or you would continue with FOLFIRI plus trastuzumab?
I think I don't see any actionable alteration beside the ERBB2. Choice of trastuzumab or lapatinib, it's your call to make as per your practical convenience, but you have to continue anti-HER2 therapy even beyond progression, just to control the disease in the best possible way. Over to you. Yeah.
Okay. Dr. Miller, I think she's there. I think she wrote something. You want trastuzumab deruxtecan? I think we can get an access from outside. That's what you suggested in the chat box, if I'm not wrong.
Yes, if there is access, we have had a few patients with biliary tract cancers that we have managed to get access to trastuzumab deruxtecan. So I think that might be an option. I'm not sure this report is particularly helpful from whichever company it's come from, but there is some data, and there are some ongoing trials in biliary tract tumors for.
So this report has come from Phobos Care. They have an Illumina platform, and they're doing a decent job in India. So it's not about I think they're doing a decent job, and so probably we'll have to take it, and it's unfair to ask them to repeat it. But then, so I think TDXT is something which is there. So I think that's from my side. I'm sitting in Tajikistan. Sorry, so I had to. I think I'll wrap it up from here. Thank you all for joining in, and I think Viraj and Dr. Somani, you can take it up from here, please.
So thanks to the panelists, and thanks to Dr. Bhuvanchuk for this wonderful discussion, and a special thanks to Madam Mukherjee also for giving the input in this particular session. So we now move to the hepatocellular malignancy portion. And for that session, we have with us Dr. Vijay Agarwal. Dr. Vijay Agarwal is the lead consultant medical oncology, Aster CMI Hospital, Bengaluru. He will be presenting the abstract from the recently concluded GIS meeting. Dr. Vijay Agarwal, over to you.
Thank you very much, Dr. Nareshwani. Thank you very much for having me here to talk on on the recent abstract presentations from ASCO with regards to hepatocellular carcinomas. So there are quite a lot of abstracts for me to choose from. So I was really spoiled for choice, but I thought I'll speak on these 3 abstracts, which could be practice changing going forward in our clinics, which is the Himalaya trial, the Keynote 394, and the Launch study. They're all phase 3 studies with good data. So we'll start with the Himalaya trial and then work our way through over the next 20 minutes or so. So Himalaya trial was a phase 3 randomized open label study looking at the combination of tremelimumab and durvalumab. So this was an IU-IU combination called steroid dosaging, given as first-line therapy in patients with unresectable HCC. So this basically included patients who had a BCLC B or not amenable for local regional therapy, or C category patients who did not have any prior systemic therapy. So first-line treatment, child pukes had to be A, and there should not have been any portal vein thrombosis. Endoscopy was not required. Patients were stratified based on vascular invasion, etiology of liver disease, and performance status. Now, this initially started as a 4-arm study, which was a priming dose of tremelimumab, 300 milligram, one-off dose, followed by durvalumab, 1500 milligram every 4 weekly. The other arm was durvalumab monotherapy every 4 weeks, and third arm was sorafenib, 400 milligrams twice a day. Now, there was another 4th arm, which was tremelimumab, 75 milligram, for 4 doses along with durva every 4 weeks. But this trial this arm was stopped after a pre-planned analysis of a phase 2, a different phase 2 study. So this subsequently became a 3-arm study because the 4th arm was stopped. The primary objective was overall survival for the tremi-durva combination versus sorafenib, and a very key secondary objective outcome was overall survival for durvalumab monotherapy versus sorafenib. So 2 primary outcomes: durva tremi combo versus sorafenib, and durva monotherapy versus sorafenib, and there were various other secondary outcomes. The testing procedures were overall survival looking at superiority for durva tremi combination versus sorafenib. The next overall survival was non-inferiority of durva monotherapy versus sorafenib with a margin of 1.08. And then the third outcome was overall survival of superiority of durvalumab versus sorafenib. So we look at baseline characteristics, nothing to take home in terms of distribution. They were reasonably well distributed across all the 3 parameters. If you look at even PD-L1 positive, about a third of them were positive across all the 3 arms, as well as AFP more than 400 was about a third in all the 3 arms. When you look at second and subsequent line therapy, only about half of them, so about 40% in the combo arm, 43 in durva monotherapy, and 45 in sorafenib, went on to receive a second-line treatment. So the vast majority of them did not get to second-line treatment. There were more immunotherapies in the sorafenib arm as opposed to the other 2 for these reasons. So this was the primary objective, the primary endpoint, looking at overall survival for the tremelimumab priming dose along with durvalumab versus sorafenib, and this was a statistically significant benefit seen in the combination versus sorafenib. So the median overall survival was 16 months in the combo arm versus 13.8 in the sorafenib arm, with a hazard ratio of 0.78, which was statistically significant. So it did meet its primary endpoint of superiority of the durva tremi combo versus sorafenib. And when you look at the 3-year overall survival, you have a 30% patients surviving for 3 years in the combo versus 20% in the sorafenib arm. So we've never seen this kind of data before. You have a third of the patients now going on for about 3 years, which is good data. Again, this was statistically significant. If you look at the forest plot, all of the parameters on the left of unity in favor of the durva tremi combo combination, and this benefit was seen irrespective of PD-L1 expression or the level of AFP, or for that matter, the etiology, whether it was hepatitis B or whether it was non-viral Hepatitis C numbers were quite small, and that's on the right of the unity. But for the vast majority of others, the benefit was there. Progression-free survival did not show any benefit of the combination versus sorafenib, all measured in about three odd months, whether you look at the combo, which is 3.78, or durva monotherapy 3.6, or 4 months for sorafenib. And we've seen this with immunotherapy before, where the benefit is predominantly in overall survival, but not so much in PFS. When you look at the secondary key objective, which was monotherapy durvalumab versus sorafenib, so you can clearly see that there was non-inferiority of durvalumab versus sorafenib. So durvalumab was not inferior to sorafenib. Hazard ratio of 0.86 with a confidence interval of 0.73 to 1.06, which is less than the non-inferiority margin of 1.08. Now, when you look at the 9 months, it was non-inferior, but following on 9 months from there, you can start seeing the curves are splitting. So you do have a fair share of patients who have durable response with durvalumab monotherapy. And when you look at the three-year survival, you have about a quarter of them making it to 3 years, as opposed to a fifth in the sorafenib arm. When you look at tumor responses, clearly there are more responses seen in the durva-tremi combo as opposed to durvalumab, and only about 5% in sorafenib arm. So more responses in the immunotherapy arms versus sorafenib. Safety, again, nothing much to write home about. Most of them were expected toxicity. Clearly, durvalumab monotherapy had the least toxicity compared to the durva-tremi combination or for that matter, sorafenib. So to conclude, the Himalayan study was a large phase 3 study with a heterogeneous group of patients. And the regime was a single priming dose of tremelimumab along with regular durvalumab versus durvalumab single agent versus sorafenib, and a median overall survival of 16.4 months for the combination versus 13.8 months for sorafenib. Again, a good third of the patients surviving for up to 3 months. Durva monotherapy was not inferior to sorafenib with a more favorable toxicity profile. So you could argue that durva monotherapy is not an unreasonable first-line alternative to sorafenib. So coming to the next abstract, which was the keynote 394. So this was evaluating the role of pembrolizumab in second-line treatment in HCC. So this study evaluated pembro plus best supportive care versus placebo plus best supportive care, second-line therapy. So this was done predominantly in Asian population, as opposed to the keynote 240, which was quite a heterogeneous population group. So this similar to 240 was patients with HCC who had progressed or were intolerant to sorafenib or oxaliplatin-based chemotherapy, which is occasionally used in China. Child pukes A category, BCLC stage C or B not amenable to local regional therapy, and of good performance status. Patients were stratified based on prior treatment, whether they were using sorafenib or chemotherapy, microvascular invasion, and etiology for the HCC. This was a 2:1 randomization in favor of pembrolizumab 200 milligrams every 3 weeks versus placebo. Primary outcome was overall survival with various other secondary endpoints. When you look at the baseline demographics, I think a few things I would like to point out. So there were about 300 patients in the pembro and 153 in the placebo group. So 85% of the patients were from China in the pembro and 86 in the placebo. So clearly, the vast majority of them were from China. When you look at BCLC staging, all of them were, but more than 90% were of BCLC C. Hepatitis B status. So about 80% of them were hepatitis B positive. So there's only very few patients who were non-hepatitis B positive in this study. And about 10%, or just shy of 10%, went on to have a chemotherapy as first line as opposed to sorafenib. 90% of them were sorafenib. So this study was predominantly conducted in China in hepatitis B patients who had progressed predominantly on sorafenib. When you look at the overall survival, The overall survival in the pembro arm was 14.6 months as opposed to 13 months in the placebo arm. And when you look at a two-year overall survival rate, about a third of them were still surviving, which is 34% versus 25% in the placebo arm. When you look at the progression-free survival was slightly better in the pembrolizumab arm, which is 2.6 months versus 2.3 months in the placebo arm. But about 11% of the patients were alive at the end of 2 years in the pembro arm versus none in the placebo arm in terms of progression-free survival. Objective responses, slightly more responses in the pembro arm, which is 12.7% versus only 1% in the placebo group. So there was a meta-analysis presented which looked at the combination of the Keynote 394, which was a predominantly China study or Asian studies, and the Keynote 240, which was a heterogeneous group of population done over 27 countries. And when you look at the overall survival was positively in favor of pembro arm with a hazard ratio of 0.79. So 14.2 months versus 12.5 months. So consistently, both the trials have shown benefit in favor of pembro versus placebo in second-line setting. But what is interesting is that you see the curves splitting at the end of 4 to 5 months. So the first 4 to 5 months, there's hardly any splitting of the Kaplan-Meier curves. The split happens only after about 4 to 5 months in favor of pembrolizumab. So you have your group of patients who tend to have a durable response, which skews your overall survival curves. And that is why you don't see significant PFS benefit, but good OS benefit. Adverse events, again, nothing major to talk about, nothing untoward, nothing unexpected. Immune-related adverse events were slightly more in the pembro arm as opposed to the placebo arm, and slightly more overall toxicity in the pembro versus placebo. So to summarize the Keynote 394, pembro showed statistically significant benefit in favor of for overall survival, progression-free survival, and response rates in Asian population in patients who have progressed on sorafenib with advanced HCC. The meta-analysis of both the Keynote 240 as well as the Keynote 394 showed pembro monotherapy to have a consistent beneficial effect as opposed to placebo, and the adverse effect of pembro was manageable as previously known. So clearly, this data reinforces the risk-benefit balance of pembro for all the patients, depending upon the study you evaluate, whether it's the 240 or 394. But the benefit was seen across the world in quite a heterogeneous group of patient population. Coming to the third and the final abstract, which was the launch study, which evaluated lenvatinib plus TACE in first-line setting. So this study was done predominantly in the Cancer Center at the Sun Yat-sen University in China, as well as the Brigham and Women's in the US. So this was lenvatinib plus TACE versus lenvatinib alone as first-line treatment for primary HCC. It was a phase 3, again, multi-center means 2 centers, and a randomized control study. So very well conducted study. Just a little bit of introduction. We know that lenvatinib is non-inferior to sorafenib for overall survival, but provides better response rates as well as progression-free survival from the SHARP study. And I think most of us have now moved to lenvatinib being the first-line treatment in comparison to sorafenib. Of course, if you're using the IM-BRAVE data of Ati-Bev, that clearly is first-line treatment. But for the vast majority of our patient population, we tend to use lenvatinib as a first-line treatment because of the data discussed earlier on. But the question is, can we make this better by combining lenvatinib with TACE? Because we know that TACE reduces tumor burden in a short span of time, particularly in the liver, and the extrahepatic disease is being taken care of by the lenvatinib drug. So with a combination of lenvatinib plus TACE would improve outcomes. So this patients who were diagnosed with HCC did not have any prior treatment, and had at least one measurable lesion in the liver based on Emery's criteria. Single lesions less than 10 centimeters or multiple lesions less than 10 centimeters. Tumor burden should be less than 50%. Child-Peaks criteria to be a good performance status and satisfactory biochemistry, blood values. Patients were stratified based on the ECOG performance status, tumor thrombus, a body weight less than or more than 60 kg, presumably related to the lenvatinib dose, as well as the trial site, whether it was based out of the US or China. 1:1 randomization was done. So TACE plus lenvatinib recruited about 168 patients, and lenvatinib monotherapy had 168 patients. TACE started 1 day after commencing lenvatinib. Lenvatinib, as per the approved dosage, body weight less than 60 kilos was 8 milligrams, and more than 60 kilos was 12 milligrams in both the arms. The primary endpoint was overall survival, with various other secondary endpoints. So when you look at the baseline characteristics, both were reasonably well balanced. But one of the things I'd like to bring to your notice is that the vast majority of these patients, so just shy of so about 87% in the lenvatinib and TACE group and 85% in the lenvatinib group, had hepatitis B, and about 2.4 and 3.6% had hepatitis C. So this trial was done in predominantly hepatitis B patients, and that is something we need to keep in mind. And whether that skews the data, I am not certain, or whether we can extrapolate this data in other etiology, I'm not so certain. But clearly, the study was done in majority of the patients who had hepatitis B, and a small number of patients who had hepatitis C, and others were about 10%. So apart from that, others were reasonably well balanced across both the arms. So when you look at the objective response rates, there was about 46% in the lenvatinib and TACE group versus 20% or 21% in the lenvatinib group. And when you look at the overall disease control, it was 92% in the lenvatinib plus TACE group and 72% in the lenvatinib group, clearly statistically significantly in favor of lenvatinib and TACE combination. And this was similar whether you use a RECIST 1.1 or an Emery's RECIST criteria, it did not make much of a difference. When you look at the overall survival, which was the primary endpoint, the median overall survival was strikingly about 17.8 months in favor of lenvatinib plus TACE, as opposed to 11.5 months in lenvatinib arm, a hazard ratio of 0.45. So I think we probably can quite dogmatically say that this was quite impressive data. So looking at an 18-month benefit with TACE and lenvatinib as opposed to lenvatinib, a hazard ratio of 0.45. And if you look at the progression-free survival, you get similarly impressive data, hazard ratio of 0.43, PFS of 10.6 months versus 6.4 months in favor of lenvatinib plus TACE combination. So all these, when you look at the subgroup analysis, they were all on the left of unity, favoring the lenvatinib plus TACE group, irrespective of various other parameters or stratification factors. So I think all groups of patients benefited from it. When you look at adverse events, there were slightly more toxicity in the lenvatinib plus TACE groups compared to the lenvatinib group, but the most of the grade 3-4 toxicities were more biochemical in terms of liver enzyme abnormalities, more in the lenvatinib and TACE groups. So to conclude, lenvatinib plus TACE was safe and effective for patients with advanced HCC, demonstrating remarkable improvements in overall survival, progression-free survival, and response rates, as well as acceptable toxicity. But this may represent a potential new first-line treatment options, and probably would be quite important in our patient population, the vast majority of them who can't afford immunotherapy and are currently on lenvatinib. And the question is whether we can add in TACE to subsequently improve their outcomes. So just my final slide, just to summarize all the three abstracts. The Himalaya was the tremelimumab plus durvalumab first line. It was a good results, but we need to wait for regulatory approvals, both FDA and DCGI. This drug is currently not available in India. So tremelimumab is not available, durvalumab is available. And obviously we need to look at the Himalaya versus IMBRAVE 150, which is the atezo-bev combination, and which group of patients would get what once we've got the regulatory approvals and the drugs are available in India. there are a group of patients who do not tolerate BEV or who can't be given BEV. And maybe those group of patients can go into this tremelimumab combo, but I think we need further discussions on how to stratify our patients and ensure that the right patient gets the right combination when made available. The keynote 394, again, good data in second line treatment. And the question is again when to give, because a lot of the patients are not getting immunotherapy in the first line setting. In India, clearly, most of our patients get lenvatinib, so there would always be scope for IO in the second line therapy. Currently, it is not DCGI approved, but if and when the approval comes, I think it would be quite an important drug our patients should be able to access. The last is probably for me the most interesting, which was the lenvatinib plus TACE. Excellent data, we can't argue with that. But the vast majority of the patients, so just shy of 90%, had hepatitis B, was hepatitis B patients. The question is, do we restrict this combination to hepatitis B patients only, or do we give it to everyone? I am personally uncertain, and I think it would be good to get some viewpoint from the others with regards to that. So that is it from me. Thank you very much.
Thanks, Dr. Vijay Agarwal, and thanks for being in the time and for the great summary. And if there is any more comments, it can be discussed further in the chat box. So now I have the honor and privilege to invite my good friend, Dr. Vinit Talwar from Rajiv Gandhi Cancer Institute, New Delhi. He is Director of Medical Oncology there. And he will be talking today about the role of the chemoimmunotherapy in the biliary tract cancer. Dr. Vinit Talwar,
sorry, Dr. Somani, sir.
Yeah. Yes,
Dr.
please.
Somani, sir, can you just look for the agenda? I think next is Dr. Raja's talk. If you can just have a look.
I'm sorry. I think what has been given to me. Yeah. Okay. So I have moved to the next session a little bit. Yeah. Sorry. So I invite Dr. T. Raja, and I can see his smiling face here. He's the director of the medical oncology at the Apollo Cancer Center, Chennai, and he will be talking about the systemic treatment in the advanced hepatocellular cancer, newer avenues beyond first line. Beyond first line means where most of the medical oncologists like me, when they finish the treatment, so what's left for the patient. So Dr. T. Raja will be giving us the ideas how to treat these patients beyond the first line. Over to you, Dr. T. Raja.
Sir, thank you, sir. Thanks for your invitation. And let me get my slides into it. Thank you, sir. Once again, I thank the organizers of the second Changing Outcome in GIcancers conference for this kind invitation. And our brief today is to look at the systemic treatment options in advanced hepatocellular carcinoma beyond first line. So that's what Dr. Satya wanted me to do. So we will try to delve upon second line and some of the third line options. So we have conventionally used the BCLC staging system for deciding which patients will go for loco-regional therapy versus which patient will go for systemic therapy. But it is very important to mention the role of childhood classification, and which has not only been prognostic, but it has always been useful in deciding which therapy a patient should go and which therapy the patient will tolerate. I mention this only because this is not only important in the first line, as we are well versed, but it is also important in the second line and beyond. So we need to keep an eye on the total performance of the patient. So when we look at the, in 2012, exactly 10 years ago, the BCLC classification will allocate therapies based on these prognostic variables. At that time, if you see the options for the systemic therapy, there was only one choice available, that was sorafenib. And around the same time, the AASLD, the American group guidelines, also would mention only sorafenib as the systemic option, and beyond that, everything else was palliative. And in 2017, 5 years ago, we had the first option of some sort of sequencing. First line with sorafenib, and second line regorafenib appeared in the NCCN recommendation, which was a category 2B recommendation at that point in time. This is the late 2020 NCCN guideline. You would see that the preferred regimens are in the first line, sorafenib, lenvatinib, and then for the first time, atezo-bev combination appeared there as a category 1 recommendation. And in the subsequent line, you had a plethora of options: regorafenib, cabozantinib, ramucirumab, lenvatinib, nivolumab single agent, nivo plus ipi combo, and pembrolizumab single agent. But in early 2021, in the first line, the sorafenib and lenvatinib were moved out of the preferred regimen into other recommended regimens. And similarly, the nivo and the nivo-ipi combination and the pembrolizumab were moved out of the preferred regimen in the second line options to the other recommended regimens. And by late 2021, this is the latest version as far as hepatocellular carcinoma goes. The recommendation seems to have well settled, and the nivo and nivo single agent has been further moved down for some useful in certain circumstances in the first line and in the second line, and the dostarlimab has appeared here in the subsequent line. So how did this evolution of these options happen? Well, look at the data set. For understanding what we will do in the second line, we need to look at what is the landscape in the first line. And in the first line, the landscape was ruled by the sorafenib with the sharp data, which appeared in 2008, which was the only option available at that time. And then 10 years later, another phase 3 data set, which was a non-inferiority trial with lenvatinib, the REFLECT data showed that lenvatinib can be as good as sorafenib, but probably a slightly better tolerance profile. And therefore, FDA and NCCN recommendations were synonymous. By around early 2019, you had sorafenib and lenvatinib as the first-line systemic options. Then came the immune checkpoint inhibitors. The Checkmate 459 introduced the nivolumab as the single agent versus sorafenib as a phase 3 trial. And then came the blockbuster Imbre 150, where atezo-bev appeared in comparison with sorafenib in the first line. And this was considered as the standard of care. That's what we thought. But within a year, you don't even have a breathing time. You have other options knocking the door in the first line. You heard the excellent presentation early on for the tremelimumab and durvalumab data, dual checkpoint inhibition, and the Himalaya phase 3 trial data is already presented in October 2021, which has shown clinically meaningful overall survival benefit versus sorafenib in the first line for HCC. And there are other similar options that are emerging close here: lenvatinib and pembrolizumab, the LEAP-002, and the tivozanib in combination with durvalumab in the first line setting, which is a phase 1b/2 trial, which has already shown a disease control rate of 71% and a partial response rate of 29%. And there are some other novel mechanisms that are emerging in the first line. This is the tumor treating field, which is demonstrated to have antimitotic activity across the board, several tumors. What is of interest is that it seems to be efficacious in hepatocellular carcinomas. And again, what is interesting with the TTF is that each individual tumor seems to need a different electricity field and different strength of the electricity field. And for HCC, it is 150 hertz, that is kilohertz, that is what is needed. And this is the HEPA-NOVA trial phase 2, which has already shown that the TTF plus sorafenib has shown an overall response rate of 18 and a disease control rate of 91%, and the phase 3 is already planned. So with this background, now we can understand what are the options with regard to the second line with patients who are either treated with the currently standard and these emerging options in the near future. So one thing is very sure, these options, including the second line and third line, are going to be ever changing, because all these first lines are going to hit, and those impacts will be considered later when we try to choose in sequence. And let's look at the role of second line with TKIs. And the first and foremost is the regorafenib data, which was presented in 2017 RESOURCE trial, which was in patients who were pre-treated with sorafenib. In this second line setting, regorafenib was efficacious because if you understand the emergence of acquired resistance with sorafenib, the resistance was due to the activation of the IGF and the FGF signaling. And regorafenib, even though it's a cousin of sorafenib, was found to have a more widespread TKI inhibition across the board, and therefore it was found to be efficacious, and it could show an overall survival advantage in the second line setting as compared to sorafenib. And you could, as compared to placebo, you would see that regorafenib shows a median overall survival of 10.6 months in patients who are pre-treated with sorafenib. And this advantage was across the board, and this was also true for AFP less than 400 or more than 400, and with the Child-Pugh score of A5 or A6, and whether the patient had hepatitis B or 6. Then in 2018 came the celestial cabozantinib data, and the beauty of this is that it is also a trial on patients who have progressed on sorafenib, but it allowed 2 prior lines. So this could be essentially a second line and a third line, and we'd see cabozantinib can do a 10.2 months median overall survival as compared to placebo with hazard ratio of 0.76. And the survival benefit was also across the various subgroup analysis that included the prior 1 line or 2 line and the regions across Asia or other regions. You would see the cabozantinib benefit was consistent. Then the other VEGF inhibitors was ramucirumab REACH2 data set, and we look at the data. And based on the original REACH subgroup analysis, the ramucirumab was shown to have efficacy on patients who have an AFP of more than 400. Therefore, a REACH2 randomized control trial with ramucirumab in patients who had a AFP of more than 400 as compared to placebo would show a median overall survival of 8.5 months as compared to a placebo of 5 to 7 months. This is the ramucirumab data in the second line in patients who have AFP of more than 400. So this is the VEGF targeted therapies that are available in the second line, and all of them are phase 3 data. The sorafenib in second line and celestial cabozantinib in second and third line, and the ramucirumab in second line for patients who are an AFP of more than 400, and all of them would show a median overall survival of 10 months. And the ramucirumab with the median overall survival of 8 months as compared to 7 months. And you can see these curves that these are now the settled players as far as TKI in the second line. And what about immune checkpoint inhibitors? Checkmate 040 is an interesting data set, which is a little bit of multi-arm, little complicated, little complex trial, but the essential part of Checkmate 040 is the arm A, B, and C. In arm A, you have the nivo-ipi combo Q3 weekly continued as nivo maintenance, and arm B is again the nivo-ipi with a varying dose combination, and arm C is only 4 cycles, and thereafter we stop. And what we see is that the arm A in particular did exceedingly well. At presentation, the median overall survival for arm A was 22.8 months. And it was also seen that in patients who had a best overall response rate, the overall survival is not reached in Checkmate 040 in patients who had a best overall response rate as compared to the overall group, which had a median overall survival of 16.7 months. And this is in patients who are pre-treated. So it's very, very impressive. Therefore, in early 2020, FDA would grant an accelerated approval for the combo of nivo-ipi for patients who are already pre-treated, in the first line. And this is the pembrolizumab in the second line. This is the phase 2 data, Keynote 224, based on which a phase 3 was mounted, Keynote 240. And this is the pembrolizumab phase 3 trial in the patients who are being pre-treated after sorafenib, either progressive disease or intolerant to sorafenib. And this is the overall survival in the PFS curves, and the median overall survival for pembrolizumab in the second line was 13.9 months as compared to placebo. And so these are the immunotherapy options that are available in the second line: nivo, single agent, pembro, single agent, and nivo plus EP. And what you would see is an overall response rate of somewhere between 15 to 20% for nivo and EP. Nivo single agent and pembro single agent, but for nivo EP, the response rate, overall response rate is 32%. And recently, we have the long-term follow-up of some of these important data sets available: Keynote 240, pembrolizumab monotherapy, and the Checkmate 040 nivo-ipi combination. A 4-year follow-up is available, which is essentially reflected on the original data set, and particularly the Checkmate 040, you see the EP-nivo combination. The curves are remaining really flat at 4-year follow-up. There are some other novel options in the second line. We are aware of the chemotherapy option in the first line with FOLFOX versus doxorubicin, which is an old data. But Dr. Ghassan Abu, this is his data on adding the ADI PEG20, and which is an arginine inhibitor And this is a trial in which FOLFOX was combined with ADA-PEG20 in patients who are pre-treated with either sorafenib or pre-treated with chemotherapy or pre-treated with prior immune checkpoint inhibitors. You would see that the waterfall plot would show an impressive response rate with ADA-PEG20 in combo with FOLFOX. That's an interesting data set. And if you look at some of these images of these patients, you look at the response, which really convinces that FOLFOX plus ADA-PEG20 has got something to do in the second line. This is baseline versus 4 month, and you see a very good impressive partial response rate with this combo. There are other interesting options that are emerging in the second line. This is the tislelizumab data, that is the rational 208 in the second line. And this was presented in August 2021. And the key points are that it has shown a median overall survival of 13.2 months. And recently, the GlaxoSmithKline has received an FDA accelerated approval for their drug dostarlimab for patients who have a deficient MMR. And recently, the peerview.com did try to put together all these emerging options, and in combination with the real-world evidence, understanding how do I kind of use this and sequence when I have so much of options, and how do I really sequence? Let's try to make sense of all these options that are available. This is something interesting about the ramucirumab that was presented in the East Asian group. This was presented in the Taiwanese Cancer Society meeting in 2021 about the ramucirumab. This is the ramucirumab data on patients specifically on ALBA score of 1 and 2. This is nothing but you further subcategorize your liver dysfunction into further scores with albumin and bilirubin, and you will have your Child-Pugh 5 subdivided into ALBI 1 and 2, and Child-Pugh 6 will become 3, and Child-Pugh 7 will become 4. So it is shown that ramucirumab is especially efficacious as long as you have an ALBA score of 1 and 2. And then in patients who have emergent ascites, you see that the REACH and REACH2 data show that the ramucirumab has got a special sensitivity in acting on this as compared to placebo. And this is the PFS and overall survival curve in patients who have emergent ascites. So this shows that in patients who have emergent ascites and patients who have liver dysfunction to the score of ALBI 1 and 2, ramucirumab is efficacious. And this is the real world data of 385 patients presented by the Chinese group of ramucirumab in patients who are already treated with lenvatinib. That's what we are looking at. We are looking at what do we do when these patients are treated with all these options. We know that there is data set in second line when they are especially treated with sorafenib, but then there are no answers to questions like what if they are treated with lenvatinib, what if they are treated with immune checkpoint inhibitors. And these data sets try to answer those questions partially. This is the data of ramucirumab after lenvatinib, and this is the data of ramucirumab after lenvatinib pembrolizumab, wherein you see the ramucirumab being efficacious in patients who are pre-treated with lenvatinib and pembrolizumab. So this opens the door of, how do we treat these patients when they come up with all this prior treatment with all the permutation? The quick summary on ramucirumab is that it is useful as a second line in sorafenib failed patients, as we know in AFP more than 400, but then also in ALBI grade 1 and 2, and also in patients who have a treatment emergent ascites. So if you want to put all of these as an algorithm, this is what we try to do. And the sorafenib is better than placebo, lenvatinib is not worse than sorafenib, and atezo-bev is better than sorafenib in the first line. So then move on to the second line, you have the regorafenib, cabozantinib, and ramucirumab, and then you probably have pembrolizumab and nivo-IP. And then if you look at the second line alone and what is the approval status, regorafenib for patients who are tolerant to sorafenib, FDA EMA approval, nivolumab FDA conditional approval, and nivo plus IP, particularly 1 plus 3 milligram, you have an FDA approval, and pembrolizumab you have a conditional FDA approval. Cabozantinib you have an approval for second line and third line with FDA and EMA approval, and ramucirumab particularly for patients more than 400. And this is the second line and beyond options: Cabo, lenvatinib, regorafenib, sorafenib, ramucirumab, and then you have the nivo-ipi and pembrolizumab. So you can kind of try and use this as second line and third line. And I mean, there is no big data set on each of this, but this is the way things are evolving, and you can take sense from these options and try to plan your therapy. This is a simple cartoon on what do you do in a real time for your patients today: Atizobev, lenvatinib, sorafenib, and then you have these second line options, and you have a third line option with cabozantinib. And if the patient is IO naive, you will be able to jumble up with all these things. So this kind of gives you the landscape, and finally you have to choose based on the patients in front of you. So with that, I sincerely thank the organizers, Satya, Bharat, Anant, and Viraj, for this wonderful opportunity. Thank you so much for listening to me.
Thanks to Dr. T. Raja. If there is any question, we can go for 1 minute. And I don't think there is any question in the chat box. So still it can be discussed with Dr. T. Raja. So I request now to, I invite now to Dr. Debra Mukherjee from the Beirut. She is Associate Professor of Clinical Medicine in the Department of Hematology Oncology, American University of the Beirut. Welcome you, madam. And we are thankful for joining us and participating actively on behalf of all of the organizing team. Over to you, Dr. Debra Mukherjee.
Thank you very much for this invitation. It's a great pleasure to be with you virtually. I'm with you from Dubai today. I'm just going to see if I can share my slides. Okay. Oh. Did that work? No. For some reason, it's not allowing me to share my slides.
Mr. Tarun?
Does the team have the slides? Yeah. Are you able to share the slides from your end?
Okay. Yeah, we'll do that, ma'am. We'll do that,
Yeah,
ma'am.
okay.
No, Tarun, why ma'am is
again?
not able to share? Why ma'am is not able to share? Because that will be better.
No, I'm not sure. Ma'am, can you just try again? Can you just share your screen again, please?
Let's try. After 2 years of Zoom meetings, it usually works. Let's have a look. Let me see. Great. So thank you so much to the organisers, and apologies for these technical issues. So I've been given the really difficult talk. Usually we enjoy reviewing the data and talking about the latest clinical trials. So the topic I've been given is systemic treatment in advanced stage HCC in patients with advanced Child-Pugh. So liver dysfunction, B+, frail patients, and these are often the patients that we see in clinic. So I think we're going to be reviewing some of the data that we have been seeing so eloquently presented, but really trying to fit this into our clinical practice of the type of patients that we see. You could put the next slide, please. These are my disclosures. And next slide, please. So we've heard about these clinical trials, and really those patients in clinical trials are absolute superheroes. Child Pu A, getting to 2 or 3 lines of treatment. And the type of patient that I normally see in the clinic is frail, elderly, poor performance status, liver dysfunction. So I wonder if that's the type of patient that you see as well. I suspect that it is. Next slide, please. So just to remind ourselves that management of especially advanced HCC requires a whole team. And particularly in patients who have liver dysfunction, we need to think about whether they're eligible for transplantation. We've heard about the value of liver-directed therapies in combination with systemic therapies, the recent data presented with TACE and lenvatinib. And we also need to think about our palliative care team, particularly looking after these patients who are frail, elderly, with very poor liver function. Next slide, please. And we've seen some of these diagrams before, looking at the recommended treatment options for advanced HCC. So if we really look for patients who have Child Pu B, they have to have pretty good performance status to be recommended for systemic therapy. And in fact, most of the clinical trials have just included patients with Child Pu A. And for patients with Child Pu C or ECOG performance status of 2 or above, less supportive care is recommended by the guidelines because their overall survival is pretty limited. But we've all had these patients in the clinic who have performance status 2, who have Child B status, who are still very keen on systemic and local therapy options. They still want treatment. So I've pulled together some of the evidence from that's recently been presented and from some ad hoc or post hoc analysis of clinical trials to see if we can help evidence-based our treatment recommendations. Next slide, please. So these are the ESMO clinical practice guidelines. And again, they are not particularly different. We do have some recommendations for further lines of therapy that we've just seen very nicely discussed, but still for these Barcelona clinic category D, best supportive care is still there as the option. Next slide, please. And these are the NCCN guidelines most recently, and atezolizumab bevacizumab is the preferred regimen, but again, only Child Pu A cases. And if we look at all of the recommended regimens in the first line, sorafenib, Child Pu A or B7, lenvatinib, Child Pu A only category 1, nivolumab, potentially an option for Child Pu B cases, and I'm going to show you the evidence for that. And we still have FOLFOX chemotherapy in there. Next slide, please. So is it just in the Middle East and in Asia that our patients don't tend to get a lot of systemic therapy? Well, actually, no. These are data presented at ASCO GI just recently, and it was a retrospective study from Canada. And of more than 1,200 patients with advanced HCC, only just over 21% of patients received any sort of first-line systemic therapy. And of those, around 11% initiated second-line therapy. So it really shows how the clinical trial populations are completely different from the population of patients that we see in our clinic. Okay, next slide, please. And we've seen this before. This is the importance of the Child Pu staging. But I'd like to draw our attention to the fact that we need to assess liver reserve beyond those Child Pu criteria in HCC. So is it cirrhosis or is it cancer which is causing that high bilirubin and the low albumin? And could the liver function and therefore this Child Pu status improve with cancer treatment? So this is where we try and stretch the boundaries a little bit sometimes. If you could show me the next slide, please. So this is a case, 75-year-old female patient, chronic hepatitis B, AFP is 4,000, and she's already had one previous TACE procedure at an outside institution. She has this huge exophytic mass. Amazingly, she's still Child Pu A, but her ECOG performance status is 2. She's pretty frail. Next slide, please. What do you think you might be able to do with this patient? Okay, so We've had some consensus statements about TACE unsuitability, and certainly those patients who have beyond 7 lesions, those who have huge tumours, confluent tumours, poorly differentiated HCCs do not respond that well to TACE. And even though this patient has a Child-Pugh A, she has a performance status of 2. So as per all of the guidelines, we may want to offer best supportive care. But certainly this is a patient who is still requesting some additional treatment. And it may be that her performance status 2 is due to her tumour. And it may be that systemic therapy will actually improve things. So I think even in this case with a lady who has a poor performance status, we still do have a role for liver-directed therapy, and we still do have a role for systemic therapy. And in fact, this lady was considered for systemic therapy as the next step. Next slide, please. We've seen these data. We've looked at the phase 3 data for TACE and lenvatinib, and I think this would be particularly a good case for the combination of liver-directed therapy and oral systemic therapy. I'm not sure that we'd be brave enough to give her bevacizumab with that large peripheral lesion, which could be at risk of rupturing. So I think this would be perhaps the ideal patient to go for TACE plus lenvatinib. Next case, please. Next slide, please. This is another case, a 75-year-old male patient known to have hepatitis B off treatment. He had COVID-19 complicated by acute kidney injury. And at that time, his lab test showed a new elevation of his liver function tests. His creatinine clearance was borderline. His Child-Pugh works out as a B9. He has a low albumin, a high bilirubin, but he doesn't have ascites, encephalopathy, or coagulopathy. So he's a B9, but we really have to sort of evaluate whether this B9 is due to liver dysfunction, due to what you'll see in the next slide is his HCC, or whether this is liver dysfunction due to liver cirrhosis. Next slide, please. So this is a huge right lobe mass. This is a scan which was done without contrast. He had a biopsy showing a well-differentiated HCC, and an EGD showed grade 1 esophageal varices. So what are our options? Next slide, please. So first-line systemic therapy for patients with HCC and Child-Pugh B+, or those frail patients. As we mentioned, all those clinical trials restricted to Child-Pugh A. This patient would not have been eligible. Do we stretch the boundaries and offer him atezolizumab, bevacizumab anyway? Do we try sorafenib? Do we try lenvatinib? Do we try immunotherapy? And just that reminder to assess that liver reserve beyond the Child-Pugh in the HCC. Could that high bilirubin or low albumin be due to his tumour? It could well be due to the tumour, that huge 16-centimetre tumour, rather than his underlying cirrhosis. Next slide, please. Next time I have to have some poll voting on the webinar. So we did have some data from the recent ASCO GI. We had a very small study looking at atezolizumab, bevacizumab in Child-Pugh B patients. And we did see that they had a lower response rate and the toxicity was significantly higher. But this really is a very small number of patients. So the 37 patients with Child-Pugh B, we had objective response rate in around 10%, as opposed to just over 30% in the Child-Pugh A patients. Disease control rate was lower, 56%, and we definitely had more toxicity. So I think we have to be very careful about recommending atezolizumab, bevacizumab in these patients. Next slide, please. These are the PFS and the overall survival curves. Again, as expected, the Child-Pugh B patients did much worse. And really, sort of, although small study, this is not randomized, these are very small data sets. We have to be very cautious with this treatment in patients with significant liver dysfunction. Next slide, please. What about sorafenib in Child-Pugh B HCC? So this is very commonly used all over the world in patients who have class B liver dysfunction. But when we look at sort of data sets, the median overall survival in patients treated with sorafenib, this is first line, was only 3.8 months in patients with Child-Pugh B liver dysfunction. So they definitely have poorer outcomes. They may be able to tolerate treatment, they may still benefit, but we have to be very, very conscious of the expected benefit with this palliative treatment. But this is certainly done and used all over the world in patients with Child-Pugh B liver dysfunction, and there may be dose reductions associated with treatment to make it more tolerable. Next slide, please. Lenvatinib, my colleague mentioned that lenvatinib is now replaced sorafenib as probably the most commonly used medication for first line for HCC in India, and certainly we are using it a lot more than sorafenib now. This is a post hoc analysis of the phase 3 REFLECT study. These are patients who within 8 weeks progressed from A to B. They had to be Child-Pugh A to get on the study in the first place. And in those who progressed to Child-Pugh B, the overall survival was 6.8 months at 8. This is at 8 weeks they had Child-Pugh B, 6.8 months with lenvatinib compared to 4.5 months with the sorafenib arm. So they're looking at all the patients who became Child-Pugh B, and they looked at their outcome in the sorafenib arm versus the lenvatinib arm. And actually, those patients who progressed to Child-Pugh B still did better with lenvatinib. So really, this is the first data that we have. This is presented at the ESMO GI meeting 2021. This is the first data we have that perhaps we can use lenvatinib for patients with Child-Pugh B, and that it would be a better potential option than sorafenib in this group of patients. So in the lenvatinib group, the overall duration of treatment, median duration of treatment was 3.2 months, and sorafenib group was 1.9 months, which underlines the poor tolerability of TKIs in these patients with significant liver problems. Next slide, please. So these are the data, and we mentioned that in the NCCN guidelines, patients who have Child-Pugh B liver dysfunction actually are now recommended by NCCN to consider single agent nivolumab in the first line. And this is from some of these data, a cohort 5 of the Checkmate 040 study, nivolumab in patients with advanced HCC. They had a small cohort of patients, but 49 patients, sorafenib naive and Child-Pugh B 7 till 8. Response rate was slightly lower than in Child-Pugh A, 12% versus 20%. Treatment-related adverse events were the same, so it did appear to be safe and tolerable. Next slide, please. And if we look at the outcome, the median overall survival with nivolumab was around 7.6 months compared to 5.4 months, which is historically with sorafenib. So they did see some clinically meaningful stabilization of liver function, and they did see some improved Child-Pugh scores, albumin and bilirubin, related to treatment effect. And as we saw, nivolumab had about the same tolerability and safety profile as in the patients with Child-Pugh A. So I think if we're looking at evidence, this is a prospective study, we probably have, although it's small numbers, we do have evidence that nivolumab could be a potential treatment option for these patients if they have access to it, and we don't feel that they're going to be well enough for a TKI. Next slide, please. Any data for second-line therapy? And we've seen Dr. Raja's very eloquent presentation of the current phase 2 data. And what do we do with those patients who are now Child-Pugh B? Do we offer them second-line therapy? Is their prognosis well enough? And actually, we do have some data. Again, this is an ad hoc or post hoc data from the Celestial trial presented at the 2020 International Liver Cancer Association conference. And we do have some data that patients treated with cabozantinib versus placebo in this very small subgroup did have some clinical benefit. And so they had prolonged median overall survival. So this is 8.5 months in the second line in patients who had progressed to Child-Pugh B liver dysfunction. So I think we do have data from this study that we do have patients who can tolerate treatment and benefit from treatment versus placebo or best supportive care in the second line. Next slide, please. What about local therapy? So systemic therapy can often be very difficult to tolerate for patients with liver dysfunction. Next slide, please. This is a poster presented at ASCO GI And I really just put it in to show that these were patients treated with SBRT to local therapy for liver lesions in patients with Child-Pugh cirrhosis. And they had high local control rates and relatively low toxicity. So I think that we really have to discuss these patients in our multidisciplinary teams and not forget about the role of local therapy for patients who do have liver dysfunction, particularly when that liver dysfunction is due to the tumor volume itself. Next slide, please. And I put this in, the elephant in the room. What is the elephant in the room with all of these treatments? Next slide, please. And that's the financial toxicity. And this is, on looking, this is the only data that I could find from India. I hope there are some others, but this is about cost effectiveness of sorafenib for HCC in India. And their conclusion was that sorafenib was not cost effective. And I think if sorafenib is not cost effective, I dread to think about the other more expensive treatment options using combined immunotherapy or other more expensive treatment options for patients who have a relatively poor prognosis. Next slide, please. So back to my multidisciplinary team and just emphasizing the role of our team, our radiologists, our palliative care physicians when we're thinking about patients who have significant liver dysfunction and HCC. Next slide, please. This is a summary slide presented at the ASCO GI after the Himalaya study. And we're looking at patients, now we have potentially the new options of STRIDE, which is the tremelimumab, can't say that, durvalumab combination of Himalaya. So IO contraindications, Child-Pugh option, we can use sorafenib, lenvatinib, we do have some data. Cabozantinib, atezolizumab, these are still in clinical trials. In patients who have contraindications to bevacizumab, high bleeding risk, we can consider dual immunotherapy. In patients who are not a combination therapy candidate or a TKI candidate, or with Child-Pugh status, we do have the option of single agent PD-L1, single agent nivolumab or durvalumab from the Himalaya data. Next slide, please. So these are my conclusions. Systemic treatment in patients who have liver dysfunction, who are frail. Many of our treatments, patients are treated outside guidelines, and I'd be really interested to hear the perspectives of the panel here. Prognosis remains poor from liver disease and from their tumours. Multidisciplinary care really is essential, including palliative care. Assessing that liver reserve, could it improve with treatment? Suitability for liver-directed therapy, even in those with Child-Pugh data. We have relatively strong data, prospective data for the use of first-line immunotherapy where it's available. The combination is not recommended, and the combination with bevacizumab is not recommended. And we have limited data for TKIs, which are commonly used in practice, but the patients and their treating teams should be aware of those lower expectations for clinical benefit. And with that, I'd like to say thank you very much for your attention. And I'd like to please encourage you all to think about submitting an abstract for the ESMO World GI, which is going to be in June and July in Barcelona, hopefully in person this time, and definitely hybrid. And the abstract deadline is the end of March, so end of next month. So we'd really love to see more abstracts from India, and please let me know if there's something in particular you'd like to be brought up as a panel session at that World GI meeting. Thank you very much.
Thanks, ma'am, for the wonderful presentation and giving us the insight in the frail patients' treatment of HCC. Now, I think there is a question in the chat box by Dr. Vinit Talwar from Delhi. So he basically wants to know that when you would not like to start the treatment with the DRN LFT, like simple, like let's say bilirubin and the OTPT. That's the question from Dr. Vinit Talwar.
Yeah, a really good question. And I think it's really looking at the whole picture. Certainly with many of our systemic treatment options, if the bilirubin is very high, we need to think about if that's going to be benefiting the patient at all. We may need to think about whether there's any biliary tract obstruction that we can address. If it's all tumor related and the patient is not a TKI candidate and does have access to single agent nivolumab, we do have some data from the Checkmate 040. So if the patient is potentially a candidate for systemic therapy with a very high bilirubin that's not amenable to stenting, I may consider single agent IO.
Thanks, ma'am. And I think with this, we move to the next session, which is being sponsored by the AstraZeneca. And I invite my good friend, Dr. Vinit Talwar from Rajiv Gandhi Cancer Institute. He's Director of Medical Oncology there. And he will be delivering the talk on the immunotherapy in combination with chemotherapy in biliary tract cancer for the management in the first line to consider as the standard of care. Dr. Vinit Talwar, over to you.
Thank you, Dr. Somani, for the kind words. And without much ado, I'll go to the topic, that is immunotherapy plus chemotherapy as the new standard of care for first-line biliary tract cancers. As all of us know, biliary tract cancer is very private to our country because it has a very high incidence in the Indian subcontinent, especially the northern Gangetic plain. And this has a very lower incidence as far as the European countries or the US is there. So generally the data is obtained from India or from certain countries in South America to bolster the treatment paradigms. So if we see that the National Cancer Registry Program, which is there, it reports about 32,000 cases of biliary tract cancers, including gallbladder cancer. And unfortunately, as the tumor profile is, 90% of the biliary tract cancers are diagnosed in unresectable or advanced stage. So patients treated with the current treatment of care, that is gemcitabine and cisplatin, have a dismal overall survival and a five-year overall survival rate of less than 10%. So there is a need to have something else to bolster this dismal overall survival rate. And India, again, as I had mentioned, has a high burden of biliary tract cancers. And in India, as such, we have 22 per 100,000, which is much more than US, which is 1.5 per 100,000. Amongst Europe, Poland has 14 per 100,000. So if we look from that point of view, we find that many patients are there of biliary tract cancers in India as compared to the West. If you see the treatment protocols, well, it is a multidisciplinary team approach in which you have to discuss starting from the pathologist to the radiologist. Of course, gastroenterologist is always there in the beginning, and then the role of the surgeon and the oncologist and the clinical nurse specialist comes into fold. The general management of the biliary tract cancers, only 10% are resectable. And when you see this, as you go up the stage, you find that most of these tumors, most of these cancers are unresectable. So the standard till this point of time was according to the ABC-02 study, in which gemcitabine plus platinum is established as the standard first-line chemotherapy for advanced biliary tract cancers, where you have a difference of about 3 months as far as the overall survival is concerned when you give gemcitabine alone vis-a-vis gemcitabine plus cisplatin. And this combination has continued to remain the standard of care, and no new therapies have come or in the recent times. So with that in mind, if you see the NCCN guidelines, the pre-immuno-oncology drugs era, the preferred regimen is gem and cisplatin. The other regimens are, of course, a combination of 5-fluorouracil and platinums, can be cisplatin, can be oxaliplatin. And sometimes you have a combination of gemcitabine, cisplatin, and albumin-bound paclitaxel. If you have the NTRK gene fusion, then if you're fortunate, then you can use entrectinib and larotrectinib. But unfortunately, at this point of time, we don't have this medicine available in India. And if you have the MSI high or a deficient MMR tumor, then probably pembrolizumab can be used as an agnostic tool as an immuno-oncology drug. But so far, just about 2 to 4% of cases are the ones which are having this deficiency of the MMR gene. So we are here where we have, we can give single agent chemotherapy or a combination in the form of gemcitabine and cisplatin as a standard in the first line, or we can have gemcitabine and oxaliplatin, or if there is some contraindication, then probably 5-fluorouracil and oxaliplatin. So these are the commonest treatment protocols which we are using at this point of time. The first study to see whether there was any improvement in the addition of immuno-oncology drugs, whether it was there or not, this was done, and this was the Meditream study in which you had the combination of gemcitabine and cisplatin plus durvalumab, or gemcitabine plus cisplatin plus durvalumab and tremelimumab. And there you find that patients who have the biomarker cohort in which the PD-L1 is high, there is a slight difference in the progression-free survival, that is 15 months versus 13 months. But the patients who had this combination of gemcis plus durvalumab, definitely there was an improvement of about 7 months. So taking a cue from this, the latest study was the gemcitabine plus durvalumab, that is the Topaz 1 study. This was the phase 3 randomized double-blind placebo-controlled study, which had a combination of the current standard, which was gemcitabine plus cisplatin, and along with that, durvalumab was added in patients with advanced biliary tract cancers. And India was also part of this global clinical trial. Fortunately, we had this opportunity to join this trial and see how our patients did in this trial in the whole of this study. So this is the trial study design. This is a double-blind, multi-center global phase 3 trial, and the key inclusion criteria were the locally advanced or metastatic biliary tract cancers, previously untreated. If they had recurrent disease, that should be greater than 6 months after the curative surgery or the adjuvant therapy. They were randomized in 1:1 fashion, about 300 plus in each arm. And one arm was the gemcitabine plus durvalumab arm, which was the case arm, and this was pitted against the current standard, that was gemcitabine and cisplatin plus placebo. And this was given up to 8 cycles, 6 to 8 cycles could be given. And after that, the patient was put on durvalumab maintenance till progression or till intolerability. So the primary objective in this was the overall survival. The secondary objectives were progression-free survival, the efficacy by the marker, that is the PD-L1 status, and the objective response rates. So this was the patient profile. You had about 330 patients in both the arms, in which IO was, durvalumab was added on one side, and about 275 patients were discontinued in the case arm, and about 322 in the control arm at later dates. These were the patient demographics and the baseline stats, and 50% of the patients in both the cases were of the intrahepatic cholangiocarcinoma. About 25% of patients were gallbladder cancer, and the rest were the extrahepatic cholangiocarcinomas. And amongst these, PD-L1 expression of more than 1% was seen in about 60% in both the arms, that is the case and the control arm. If you go to the one of the important parameters, that is the primary endpoint, the overall survival, you see that the curves start separating after 6 months, and at 1 year it is 54.1% versus 48%. And this keeps on increasing till 2 years. So at 24 months, the overall survival was 24.9% versus 10.4%. So this had a very healthy hazard ratio of 0.80 and was statistically significant. And coming to the subgroup analysis in these patients, you see this forest plot, you find that all the factors, whether it is the age, the race, the performance status, irrespective of the tumor location, the disease status, which was unresectable or recurrent, or it is the PD-L1 expression, you find that they favor the durvalumab and the chemotherapy arm. And in all these, it has a healthy hazard ratio of about ranging from 0.8 to 0.75. The secondary endpoints which are there, that is the progression-free survival, you find that again, after about 3 to 4 months, the graph keep on separating and you have a statistical difference in the progression-free survival even after a period of 12 months. You can see the graphs are splaying up and it is plateauing. So that is a good sign at this point of time of analysis. If you see the tumor response per se, you find that the overall response rates were 26.7% versus 18.7%. And they continue to keep responding over the period of time, that is till about 18 months. So the duration of response, the median time to response, the total disease control rates, all of these factors are benefiting the combination of chemotherapy plus IO, that is durvalumab. And you have about 7 cases, that is 2% of cases had a complete response vis-a-vis 0.6%, which was there in the chemotherapy arm. And a healthy partial response in about 25% of cases vis-a-vis 18%. So whichever criteria you match, you find that there is a benefit as far as the response rates are concerned and also the survival indices. So no treatment is bereft of the side effects. If you look at the summary of the adverse events and treatment exposure, you find that you have the side effects of the conventional chemotherapy drugs, but along with that, you have about 12.7% patients who had the immune-mediated adverse events which were there. And amongst the adverse events, the grade 3 and 4 adverse events were seen in about 22 to 23% of patients in both the arms. It was not only in the arm in which durvalumab was there, whether they were the hematological side effects or they were the non-hematological side effects. So that was there in both the arms. And the immune-mediated adverse events, if you see, the commonest was hypothyroidism in more than grade 3, and this was about 2 to 2.5% of cases.
Dr. Vinit, you are left with the 2 minutes only.
Yeah, I'll be finishing.
Yeah.
And the others are, you had patients of diabetes mellitus and the hepatitis which was there. So to conclude, Topaz 1 is the first global phase 3 study to report positive results, testing immunotherapy plus chemotherapy as the first-line treatment for advanced biliary tract cancers. It met its primary endpoint at the pre-specified interim analysis and demonstrated a statistically significant and clinically meaningful prolonged OS as compared to the placebo plus gemcitabine and cisplatin. And the addition of durvalumab, as I showed you, did not add any additional toxicity. So durvalumab plus gemcitabine and cisplatin is an effective first-line therapy and could become a new standard of care for patients with the advanced biliary tract cancers. So I thank you for your patient hearing, and I think I'll stop here.
Thanks, Dr. Vinith, for being well in time and being very crisp in your presentation and defining emerging role of the immuno-oncology drug along with the chemotherapy in the first line. And as I'm not able to see any question in the chat box, so we move on to the next session. And we have with us the well-known figure in this field, in the field of the GI oncology, Dr. Axel Grothi, a medical consultant at the West Cancer Center, University of Tennessee, from US, and he will be giving us the insight in the role of the ICI in the colorectal cancer, when and how to select the appropriate patient. Dr. Axel Grothi, once upon, welcome and thanks on behalf of the organizing team. Over to you, Dr. Axel.
Yeah, thanks for having me and allowing me to present on my favorite topic, meaning how to select patients for treatment in colorectal cancer. These are my disclosures here. I would like to give some background and early data, that really ushered in the era of immunotherapy in colorectal cancer. First of all, immunotherapy across oncology targets the hypermutant genotype. And how do we get hypermutation? There are two different ways. Number one is to have exogenous carcinogens like sun exposure, smoking, that create tumors that are characterized by a lot of mutation which then respond to immunotherapy. The other way is the internal mechanism of mismatch repair deficiency that tumors just cannot repair the many errors in DNA replication that come about in their normal lifespan. So we have mismatch repair deficient tumors that also have a lot of mutations. And these hypermutations are really the basis for generation of neoantigens expressed on the surface of tumor cells, and elevated neoantigen load is associated with response to immunotherapy in colorectal cancer. And we've known this now for quite some time, actually almost 6 years, when we had first data in a later line setting with pembrolizumab and nivolumab plus minus ipilimumab come about, that mismatch repair deficient tumors really respond very well and prolonged to single agent or combination therapy with immune targeting agents. Now, the most important development, however, is really moving immunotherapy in metastatic colorectal cancer into first line. And we have to talk about the pivotal Keynote 177 study that really served as basis for a lot of approval across the world for pembrolizumab in first line in mismatch repair deficient or MSI high tumors, randomizing pembrolizumab in first line to investigate a choice of doublet chemotherapy with or without a biologic agent. And importantly, there was an optional crossover from chemotherapy to pembrolizumab. And as you'll see later, about 60% of patients who started with chemotherapy eventually had an immune oncology agent in their course of therapy. There are two primary endpoints, progression-free survival and overall survival. And the initial data were actually really based on progression-free survival. These are the ones that really allowed this study to be published in New England Journal of Medicine. There's an interesting feature, though. On the one hand, the study is definitely positive for pembrolizumab, and you see this plateauing of the pembrolizumab curve over time. But there's also this feature of a crossover, and there's a patient population which apparently does not necessarily benefit from pembrolizumab alone, a single agent, even though these patients are MSI high. And this is actually not the group of patients with BRAF mutation. We had initial thought, that BRAF mutant tumors that are associated with MSI high status might be the ones who do not respond as well to pembrolizumab, but that's not the case. You can see here overall, except perhaps for the KRAS, wild-type KRAS mutant tumors as indicated by the error, every subgroup, pre-specified subgroup actually benefited from pembrolizumab. But we still have to acknowledge, there's this progressive disease phenomenon on pembrolizumab, almost 3 times higher rate of progression of disease as best response compared to chemotherapy. And we have not yet seen good analysis about, diving into the subgroups of, are these patients that have, let's say, lower tumor mutation burden, which MMR proteins might be affected, sidedness, PD-L1 expression levels, etc. There are a lot of questions we have to characterize these patients that have primarily progression of disease. Then, of course, could be pseudoprogression, but I don't think this is really explaining this situation. Overall, however, if you look at the depth of response and you look at the numbers of patients that responded in this waterfall plot, pretty impressive benefit for pembrolizumab as single agent over chemotherapy. But it's not just response that's important, it's also duration of response. And as you can see here, patients who have a response will likely have a very durable response. It's something we've seen in immuno-oncology overall. If you have a patient that responds to immune therapy, normally these patients actually respond very well. And when I start a patient first-line pembrolizumab or nivolumab, ipilimumab, actually I put in curative intent even in stage 4 disease. Updated data with longer follow-up now presented at ASCO last year, but here, Andre, you can see overall survival is hazard ratio, a 26% reduction of death events on the study, a p-value of 0.036 looks statistically significant, is not statistically significant because it's a co-primary endpoint. So while this is not statistically significant, it is likely explained by the fact, as I mentioned, that about 60% of patients will eventually have access to immunotherapy. It's not a now or never access to immunotherapy. It's a now or later access to immunotherapy for most of these patients. So that can affect the overall survival. Now, you might think, if I can salvage patients with later lines of immunotherapy, why shouldn't I start with chemo and then move to pembrolizumab? Now, my counter argument is, the toxicity of these treatments are very, very different. Pembrolizumab is much better tolerated than chemotherapy. And a lot of patients, as I said, durability of response, curative intent, will never need to start on chemotherapy once they start on pembrolizumab. They will not even go to second-line therapy because they might have a complete response. And then we also see data on quality of life in various instruments, the ERTC assessment. You can see that in every aspect, pembrolizumab functional scale, symptom scale is superior to chemotherapy. Quality of life overall actually improves on pembrolizumab compared to chemotherapy. So patients do better because their cancer is being treated and they really don't have that many side effects. Same for fatigue. And the time to deterioration of quality of life and physical functioning is also much better with pembrolizumab than with chemotherapy. So there's really no argument for me to not use pembrolizumab or immunotherapy in general in first line. So what about combination chemotherapy, combination immunotherapy? We have some data in first line from the Heinz Lenzer study recently published in JCO, 45 patients, nivolumab plus ipilimumab. But you can see the longer they waited on the left-hand side, 14 months follow-up, 29 months follow-up, the better the response, the better the waterfall plot actually looked. And on the right-hand side, you see the durability of these responses, again, a hallmark of immunotherapy. Interestingly, the rate of progression of disease in first line with this nivo-ipi combination was only 13%. Remember, in pembrolizumab was 29%. It's hard to compare side-by-side phase 3 data randomized, and here a small 45-patient single-arm cohort, but it could very well be that combination immunotherapy prevents some of these progression of disease that we've seen. And again, durability of the effect, you can see the progression-free survival curve and the overall survival curve, they plateau out. Efficacy is independent of RAS and BRAF status in this small cohort, and 2-year progression-free and overall survival rates over 70% are very, very impressive. So can we use combination immunotherapy after failure of single agent IO? For instance, the patient responded to pembrolizumab and then upon progression, should they be treated with combination nivo-ipi, for instance? And there are only very, very few case reports. This is a patient from MD Anderson, which was presented several years ago, actually, that patients who actually had pembrolizumab therapy and eventually had progression of disease with MSI-high tumor and responded to a combination of nivolumab and ipilimumab. But it's an anecdote. This is not evidence-based care, but I think it would be interesting to run clinical trials in this setting. What about neoadjuvant immunotherapy in these patients with mismatch repair deficient? Now, neoadjuvant therapy in colon cancer is linked to the Foxtrot study, which was not linked to, not only focused on MSI-high tumors, They looked at locally advanced colon cancers, and they gave neoadjuvant 3 cycles of FOLFOX-like therapy with or without panitumumab. This is not what I'm interested in. I'm actually interested in the subgroup of patients with deficient mismatch repair. On the right-hand side of this slide here, you can see that these patients on FOLFOX did not show a lot of regression compared to the patient with proficient mismatch repair, so MSS tumors, indicating that the MSI high deficient mismatch repair tumors are relatively resistant to chemotherapy. And this is something we have observed in many other cohort studies now. Now, this might be important for patients with rectal cancer, where we more and more move toward total neoadjuvant therapy, combining chemotherapy and radiation therapy before resection, potentially also non-operative management. So what is the efficacy of immunotherapy in mismatch repair deficient rectal cancer? There are not that many, but you know what do we see? And there are more and more data come out from single-arm studies at this point in time. The data from Memorial Sloan Kettering presented at ASCO GI just a few weeks ago looked at exactly that, dostarlimab, which is another PD-1 antibody, small numbers of patients. They want to have 30 patients. They only reported on about 15. And they used dostarlimab as initial therapy for stage 2 and 3 mismatch repair deficient rectal cancers. And as you can see here, this was very impressive. They looked at radiographic responses and endoscopic responses from on therapy, and almost every patient on dostarlimab, on this PD-1 antibody, had a complete response, and one patient a near complete response endoscopically. When you look at the data that they have right now, confirmed data on 11 patients, 100% of patients, 11 of 11, had a clinical complete response and will be moved to non-operative management. This is really striking and can potentially change our standard of care. And it's reminiscent of some data we've seen actually from a European study where a combination of nivolumab and ipilimumab was published actually in Nature Medicine. At that time when I saw the data, I did believe that 20 responses in deficient mismatch repair with 12 pathologic complete responses. So these patients actually underwent surgery, but there were also responses in impressive responses in MSS tumors, meaning proficient mismatch repair tumors. I think this still needs to be elucidated a little bit further before I move this into my lines of therapy. What about MSS tumors, IO therapy plus chemotherapy in the MSS mismatch repair proficient colorectal cancers? Data at ASCO GI just recently, the long-awaited checkmate study with the idea that if we add nivolumab, if we add a PD-1 antibody to chemotherapy, can we overcome the immune resistance? So this was a randomized study, about 200 patients, 2-to-1 randomization to the addition of nivolumab to FOLFOX plus minus bevacizumab in first line. And you can see here, it does not work. And, they did include some patients, 13 patients with deficient mismatch repair. It could very well be that the small, statistically not significant separation toward the end is related to these 13 patients that actually had a chance to respond to nivolumab here. So some additional points. I want to highlight one thing that I came across just recently in one of my patients, pitfalls in reading molecular reports. So I have this FoundationOne liquid biopsy test of a patient, 45 years old, metastatic colorectal cancer. And you look at the first page here and there's nothing that you would action on, no reportable alteration with companion diagnostic claims. So this is really devastating for this patient, nothing to target. But you go to page 3, all of a sudden you see there's a high TMB with 512 mutations per megabase. This is one of the highest I've actually seen. And this is all related to a POL-E mutation that has a very high allele frequency. And this is a hypermutated tumor. This is MSS, so MSI high is not detected in this report, but it's a tumor that is potentially very responsive to immunotherapy. I started this patient on pembrolizumab and he had a complete response. So this is something you need to really look at, even if the patient's MSS per diagnostic biopsy here, a POL-E mutation, hypermutated tumors make these patients respond to immunotherapy. Now, what about mutation? You already heard that the FDA approved pembrolizumab tumor agnostic for so-called high TMB cancers with a cutoff of 10 mutations per megabase based on the foundation tissue assay. But we have to keep in mind that these tumors that were included in this analysis were not common tumors, not colorectal cancer, not breast cancer, not non-small cell lung cancer, etc. So I strongly believe that if we have a patient, we see this once in a while, with a TMB of 11 colorectal cancer MSS, these patients should not be treated with pembrolizumab. We have no indication, no data that these patients will actually respond. So a summary and conclusion, IO therapy has revolutionized the treatment of malignant diseases. Right now, only patients with MSI, deficient mismatch repair tumors, benefit from immunotherapy, and the POLE hypermutated tumors. I believe IO therapy is standard of care in these patients. We have randomized phase 3 data. I do believe if the higher response rate for Nivo-Ipi could be used in patients when you need a reliable response and treatment is conducted with curative intent. A very interesting field is to look at the duration of immunotherapy with ctDNA MRD monitoring, because I tend to stop patients actually now more and more based on ctDNA negativity. And neoadjuvant therapy is, I think, very likely emerging as standard of care in these rectal cancers and locally advanced cancers that are MSI high and deficient mismatch repair. With that, I'll close and I'll thank you for your attention.
Thanks, Dr. Axel Grothi. We pay our respect once again to you. And if there are any questions for discussion, we still have some time. So is there any question from anybody? So if there is no more question, then we continue to the next session. And I invite Dr. P. Satyadatta, organizing secretary of this 2 days meeting, to continue the proceedings. And so there is one question in the chat box before we move to the next session from Dr. T. Raja. Can we identify cold tumors? This question is to Dr. Axel. How to identify cold tumors?
Yeah, that's a great question. And, we're working on some immune parameters, like T cell infiltration, HLA expression pattern, et cetera. When you see new molecular reports come out, for instance, from Caris, they give you a lot of data on pre-existing immune infiltration. And I believe, those are the first ones that we need to consider, like similar to the immunoscore assay, which are being done. But right now, beyond, let's say, the MSI status and POLE in colorectal cancer, at least, there's not a tumor that we can positively identify to be associated with response to therapy. But I really hope that with more immune modulatory combinations, LAG3, TIGIT, those agents in combination with PD-1 antibodies plus VEGF inhibition, there's going to be a class of agent in combination that will hopefully make tumors more immunogenic. And we need a lot of translational studies to actually see the effect of our interventions on the microenvironment. And unfortunately, I believe it will not be easy to have preclinical models predicting the efficacy of these treatments and which tumors are hot or cold. We really need patients in clinical trials because the immune system in humans is much more complex than what an in vitro system or model can replicate.
Professor, if I may ask one question. Professor Naresh sir, can I ask?
Yeah, please go ahead.
Professor, the dilemma is that, now we know that definitely some of them don't respond, early progresses, you presented that. But at a conceptual level, some of the GI tumors, particularly the esophagus and the gastric, have worked well with the chemo plus immune checkpoint inhibitor combos, which didn't work out well in other places. Even among the colon, you see this, right versus left dilemma and all that one. Again, there are a subset of people who would argue that whenever there is a right patient, doublet is better than a single IO and all that one. So can you clarify this base concept on how do I really finally select which patient and not, Professor?
Which patient for immunotherapy or for what treatment?
Yeah, comfortably. So, for immunotherapy single agent or immunotherapy either as a doublet or immune plus chemo. How do I approach that question?
Yeah. So immune plus chemotherapy, we're waiting for data on that. That is something which I would still believe, we need to see. If I have a patient that is threatened by tumor load, where you need a response, you need a reliable response, I have done two things. Number one, I've started with nivolumab, ipilimumab. I believe that let's say the risk of progression of disease is lower. And I have in one patient actually which worked quite well in a threatened tumor situation, started with a triplet chemotherapy triplet, FOLFIRINOX or FOLFOXIRI. And then I got the result of the deficient mismatch repair. So the MSI high status lead, it took some time for me to obtain that. And this patient had an excellent response to the initial chemotherapy already, but then I switched him to pembrolizumab when I saw this, to nivo-ipi actually when I saw the data. So it really depends on your clinical situation. I think if you need a response, if you really need a response to turn things around, liver function might be compromised. It's either starting with chemotherapy as a triplet, or if you can, or using a combination immunotherapy, as I mentioned. Hope
So
that makes sense.
There is one more question in the chat box. Does it make sense to look for the MMR status specifically as a marker for predicting the response to chemo on conditions where chemo is being considered in non-metastatic setting?
Yeah, so we do obtain MMR status in all patients with colorectal cancer and gastric cancer and biliary cancers, as you know, because you want to find these patients. And in my experience actually really mirrors the result of the Foxtrot study. So most of patients with deficient mismatch repair will not respond to FOLFOX. They will not respond to FOLFOX at all. And actually had a patient who really rapidly progressed through FOLFOX, and he was deficient, has deficient mismatch repair. And normally when you had rectal cancer and MSS tumor, they do normally respond actually quite well when you start chemotherapy. When they have pain, when they have obstructive symptoms, you give FOLFOX, and within 2 to 3 weeks, patients actually do better. So you have a very early read. So the data are really accumulating that these patients with deficient mismatch repair, rectal cancer, which are not that many, they should receive immunotherapy up front. I mean, you cannot beat the data from Memorial, that you just saw. 11 of 11 patients with a clinical complete response after a single agent PD-1 antibody. I think that's really impressive and should influence your clinical practice.
Thanks, Dr. Axel. And so let's move to the next session. And for that, to coordinate, I invite our organizing secretary, Dr. Satya Dattatreya. Over to you.
Thank you. Thank you so much, sir. And we'll now take this forward. And Dr. Vishwajit Dobashi is my close colleague from JIPMER Puducherry. He is the additional professor there. And he has a keen interest in microbiomes. So we requested him to enlighten us upon microbiome in young onset colorectal malignancy. Vishwajit, over to you.
Thank you so much, Dr. Dattatreya. Am I audible and the
yes,
slides
very much,
visible?
and we can see your slides too. Please proceed.
Okay, thank you. So we are moving from a kind of different field from the cytotoxic, the conventional treatment, to something which is promising. Probably the next decade would highlight whether this would become the standard of care. And this is one area which is close to my heart because we are working, myself and my colleague are working on this area. So the topic is on microbiome in young onset colorectal malignancies. And if we look at the incidence and mortality of colorectal cancer overall across the age group, there seems to be a decrease in the incidence and also an improvement in the survival with a decrease in mortality. And if you see the incidence in the country, Chennai probably leads the incidence with 3.5, much lower when compared to some countries like Korea, US, and Australia. So is there something different happening in the young patients? Yes, there seems to be. with the median age seems to be from diagnosis seems to be decreasing from 72 to 66. So we are trying to see more number of young patients developing colorectal cancer, and also that of the estimated cases in 2020, there seems to be quite a chunk of patients in the age group of less than 50 years. And actually, if you see the incidence by age group, the incidence seems to be decreasing in age more than 65, whereas patients with less than 50, the incidence seems to be rising. And if you actually go by again the age groups, you can clearly see that between 50 to 64, there seems to be a decrease in the incidence and the mortality. Same thing for patients above 65. But if you again come to the young patients between 0 and 49, there seems to be an increase in the incidence of malignancy. So is this data true for our country? So there is one publication in 2019 where they looked at the incidence rates in India. And if you see for young adults, there seems to be definitely an increase in the incidence, 2.7 to 3.5. But even in the elderly population, there seems to be an increase. So not sure whether India is following the same as the West. Before we go into the topic specific, we just need to highlight on the pathways of carcinogenesis. And we know that the colorectal has generally two pathways. One is the classical adenoma carcinoma sequence, which is through the APC and the KRAS gene. And the second one is the serrated pathway, which is by the BRAF, MLH1 and the MSI. Between these two, there seems to be another pathway, which is the alternative pathway, which is probably the pathway for the CPG island phenotype with the BRAF and the MSS. So these are the three major pathways of carcinogenesis in colorectal cancer. For long, the colorectal cancer risk factors, the genetic seems to be 1/5 and 4/5 of these patients are sporadic. And the traditional risk factors have been alcohol, smoking, obesity, red meat consumption, fat and processed food, and low fiber intake. And the recent ones which have been identified are the sedentary lifestyle and the microbiome. So if you go and look at the early onset colorectal cancers, the risk factors, the hereditary risk factors seems to be slightly higher in this age group, with 15 to 20% having hereditary. The inflammatory bowel disease and positive family history seem to be higher again. The symptomatic, most of these patients are symptomatic at diagnosis, with more than 50% having rectal bleeding, 30% with abdominal pain, and 15% having weight loss. And most of them, majority of them are again, left-sided CRC seems to be around 45%, and most of them present in advanced stage. Now, if you look at the factors which will determine the development of the early onset colorectal malignancy, there seems to be some of these common factors, which are external environmental factors like infections, radiation, alcohol, smoking, diet, physical activity, antibiotics, and medications. At the same time, we have also identified some of this internal environmental factor which might be influential in the development of this colorectal cancer, and that's are metabolic factors, oxidative stress, gut microbiome, inflammation, and hormones. And this is the area which today we will try to look at. What is the influence of this gut microbiome on the development of colorectal malignancy? So if you look at the landmark research on the microbiome and the colorectal cancer in 1968, was the first time they found a link between CRC and the industrialized countries. Subsequently, the next year, they found that the Ugandan and the English gut bacterial composition were completely different between these two countries. In 1970s, they found that a high fat diet and a low fiber diet is associated with an increased risk of CRC. In 1977, they identified a species called a Streptococcus bovis, which was associated with CRC. Then subsequently, for the next few years, there was not much of development in the microbiome field, but recently in the last decade, there seems to be a development. And in 2012, the bacterium called the Fusobacterium nucleatum was clearly associated with CRC with multiple studies and meta-analysis available. And subsequently, they also developed that the bacterial biofilm in the proximal colon was associated with CRC, and a low fat, high fiber diet intervention studies seem to mark, and they found that this resulted in decrease in the pre-cancer biomarkers. So, and in 2018, they actually took bacteria from individuals with familial adenomatous polyposis and induced them in, and that induced tumors in the mice. So just a general data on microbiome. So the microbiome is currently now considered as the largest organ in the body after the skin. It can weigh somewhere between 1 to 2 kgs, and 95% of this bacteria are found in the GI tract. And in fact, if you actually spread out the microbiome, it will be as big as 2 tennis courts. And the ratio of the number of microbes with the human cells is very high, with 10:1. And if you actually lay open the entire bacteria, it can go 2.5 times the circle of the earth. And the most common types of gut microbiota include the bacteria, archaea, and fungi. And there are 4 main factors which are involved in the dysbiosis of the gut microbiome, which eventually lead to the development of colorectal cancer. And if you see, there are few bacteria which are directly associated with the colorectal cancer, but there are others which are associated with colorectal cancer and are found in abundance in the fecal and the tumor samples. So the direct implication of the bacteria involved are E. coli, the bacteroides, Enterococcus and Streptococcus, and the associated bacteria which are increased in abundance are the Fusobacterium, Peptostreptococcus, and Prevotilla. Now, if you actually go by the bacterial diversity in the GI organ, we can see that it varies among the different organs. If you take the stomach, the Lactobacillus and Helicobacter are the predominant bacteria, whereas in the jejunum, you see Bacilli, Acinetobacteria, and Corynebacteriaceae. And when you come down to the colon, you can see the bacteroids. Now, again, if you go by whether you see them deep into the epithelial surface versus the intestinal lumen, again, the bacteria are completely different. And also, we know that over the years, from the birth, the complete microbiome changes in a human body. And there are multiple factors which result in this change. Now, there are 2 classical hypotheses or theory behind how microbiomes are directly related to development of colorectal malignancy. The first model is called the driver-passenger model. It's similar to a driver and a passenger mutation, which we generally see in a malignancy. So similarly, we have a driver bacterium, and this bacterium directly result in the mutation of the genes. Whereas the passenger bacterium, once the mutation occurs and there is a damage to the epithelium, then the passenger bacterium starts to invade. They grow in numbers. They in fact outnumber the driver bacterium, and these passenger bacteria release a lot of toxins, and these toxins can again damage the DNA and can result in malignancy. So the driver passenger theory was put forth by Salma et al. And they said that the driver bacteria locally initiate cancer by DNA damage. So the classical example is the colibactin genotoxin, which is a kind of E. coli and causes DNA damage and induces cell mutation. The Bacteriolus fragilis is basically a passenger bacteria which causes DNA damage, degradation of the E. cadherin, and thereby the spread of the malignancy. The second theory which is put forth is something called as the keystone pathogen, where you have a key bacteria to start with. Let's take this an example of a oral microbiota which is called the Porphyromonas gingivalis. So this forms the keystone pathogen, and this keystone pathogen actually initiates a complementary pathway, and this complementary pathway in fact inhibits the leukocyte killing and thereby increasing the number of passenger bacteria. So this passenger bacteria rises because of this single bacteria, which is called the keystone pathogen. So it could be a rare pathogen resulting in actually the inhibition of this leukocytes and resulting in an increased number of passenger bacteria, resulting in inflammation. Now, actually, they have looked at in cell models where they have tried a C5AR antagonist, and the moment you inhibit this antagonist, this phenomena is inhibited. Now, the second type of keystone pathogen, this could be a rare keystone pathogen, as I said, and the second could be a dominant pathogen. So the Salmonella typhimurium is one of this bacteria which causes a dominant pathogen, where actually over a period of time, this bacteria releases toxins and kills the good bacteria, and thereby taking over the complete microbiota of the system and resulting in malignancy. So this is again the short thing, that a small amount of bacteria, that is the first type, rare bacteria, or you could have an increased bacteria. Now the bacteria, a lot of bacteria have been shown to have pro-oncogenic mechanisms by various metagenomic studies they have shown. And one of the bacteria, which is called the Fusobacterium nucleatum, seems to be the bacteria which could be very useful in your diagnostic, and seems to be also resulting, though it's a passenger bacteria, seems to be an increase in abundance in the colorectal feces, and resulting in modulation of the various pathways. Now, when you go by various bacteria, there are some of these bacteria which are increased, but there are some protective bacteria which is also decreased. And this protective bacteria, if decreased and a balance is lost between the bad bacteria and the good bacteria, which will result in a malignancy. Now, there are different mechanisms which the microbiota can follow, which can cause carcinogenesis. One is inflammation, then the pathogenic bacteria and various virulence factors, then the direct genotoxins, as we saw. This could be direct effect on the genes, as in the driver bacteria. There could be the neutrophil cell resulting in an oxidative stress, resulting in release of causing DNA damage, and also there could be different metabolites. It also could form a biofilm over the bacteria, and this could prevent the degradation of the bad bacteria. Now, if you look at the microbial dysbiosis in the early onset colorectal cancer, it starts very, very early in the life, probably as early as into the birth. And we have there are a lot of studies saying how the microbiota varies between children who are delivered by cesarean section versus vaginal section, and how their microbiota change over the next few years. And we have so this early exposures can result in subsequent prolonged exposures of various environmental toxins like the food, alcohol, lack of activities, and antibiotics, which can result in a microbiota dysbiosis. Now, the common changes which occur in the gut microbiome in young CRC are one, with the dietary intake. With the protein, fat, and carbohydrates could actually mark what microbiome is available in the colorectal malignancy. Hence, it is very, very important to look at the dietary pattern. The altered gut bacteria, as we discussed, there could be good bacteria, there could be a very bad bacteria, and the balance is altered. And third is the biological effects, which alters the immune system. So this bacteria could directly result in immune system, resulting in the pro and anti-inflammatory metabolites. In fact, there is a lot of data now coming up that the resistance of many of this immunotherapy drugs could actually be reduced by altering the microbiomes in the gut. And the various host diseases also could influence the gut microbiome. Now, the pathogenesis, again, for the early onset colorectal cancer is again similar to as discussed before. There is an initiation phase, which is by the E. coli. There could be then there is a promotion phase, and there is a progression or the immune invasion and metastasis phase, which is led by the Fusobacterium. Now, different studies are there where they have clearly shown what are the bacteria which are different between the normal mucosa and the colorectal malignancy. And again, there is a study where they have looked at the difference between the bacterial pattern in patients less than 50 years and above 50 years. And there seems to be a definitive differentiation between the bacterial pattern which you see in the old colorectal cancer patients versus the young cancer patients. What about data from our country? There seems to be very limited data with respect to the microbiomes and malignancy in the country. And one of this paper recently published in 2019 shows that the gut microbiome between the normal and between the healthy and the colorectal malignancies are completely different with little overlap between them in our country. And if you actually see that we are completely different from the microbiomes from the Chinese and the Austrians. So there seems to be a completely different microbiome pattern in our country. And that's why it's very important that we study what is the kind of pattern in our country is. And also they found that these are the bacteria which were enriched in the colorectal versus these were the bacteria in the healthy enriched healthy patients. And one of the bacteria which actually was not seen in the Western population as well as in other studies, in the Chinese studies, was a bacteria called flaminofactor. And these bacteria seems to be, they also did a metagenomic study, and they have shown that these bacteria seems to be a driver bacteria which can result in development of a colorectal malignancies by also directly developing toxins. So the last.
Sir, can we request to conclude, please?
Yeah, I'm just concluding. Just 2-3 slides on how this potential application could help in screening biomarker, prognostic and predictive biomarkers, and gut modulation using prebiotics, postbiotics, and diet and fecal transplant can really help in malignancy. So at our center, we are doing 2 important projects. One is already started, which is an ICMR funded project. 6 centers are included. This is in gastric cancer. And the second project, my colleague, Dr. Smita is doing, and she is trying to map the hierarchical association of the various microbiomes, the metabolomics in the clinical outcomes in obesity-related colorectal cancer. So the last slide, the take-home message is young onset CRC is a distinct clinicopathological entity with an inferior survival. Sedentary lifestyle, microbiome and diet seems to be modulating the young onset CRC. The driver and passenger bacteria theory seems to be the one which is driving this microbiome related to carcinogenesis. There's a distinct pattern of microbiome in young onset CRC compared to the old CRC. Genomics and metabolomics are key to deciphering the role of microbiomes, and future lies in modulation using the pre, post and probiotics and diet and FMT. Thank you.
Thank you so much, Vishwajit. I mean, it was a completely new dimension you showed us, and we as practicing clinical oncologists are not really into this. We are not seeing the tangent, but thank you so much for enlightening all of us. It tells all of us that that's one more dimension we all need to look into. And the future seems to be the microbiome. Thanks, Satan. Thank you, sir. That was very crisp and very clear. With that, we now come to the last and in reality, a complete summation of what all we should do in clinical practice. Dr. Vamshi Krishna is the director and the head of medical oncology in the AIG hospitals in Hyderabad. And how do we map the ideal drug sequencing in the management of metastatic CRC? So I think that's very important topic, and that will possibly give us a complete summation of Dr. Axel Grothi's talk and Dr. Vineet Talwar's talk. Vamshi Krishna, over to you.
Thank you, sir. Good evening, everyone. So mine is a sponsored session, and I will be going back to talking about, despite everything else, sometimes old is still gold. When we discuss the sequencing and the drugs available for us for use in the management of CRC, we have the chemotherapy. Chemotherapy is still not displaced for any section aside from probably the MSI high. MSI high at this point would probably go for an IO therapy at the beginning, not going into this part. But remember that MSI high is less than 2 to 3% or maybe a little bit more in the Indian population. So for us, the major backbone of treatment remains chemotherapy, the FOLFIRI, the FOLFOX, the FOLFOXIRI, and the CAPOX. Along with that, we do know that the anti-VEGFs and the anti-EGFRs help us in increasing the survival by a certain amount of rate. And between the anti-EGFRs, you have the cetuximab and the panitumumab. The anti-VEGFs, we have bevacizumab in the first line, aflibercept not available for us, ramucirumab only in the second line onwards. Now, after all our permutations, combinations, the way I look at it, the major changes have come about for the immunotherapy, that is a small segment, and the colorectal with liver metastasis, both the resectable and the unresectable, where there has been a lot of data. But the garden variety metastatic ones, well, there have been changes, but like I said, old still is gold. What we need to emphasize is that the right treatment sequence has to be done, and that is the key to optimal treatment. This is the ESMO Pan-Asian Guidelines 2018. And to be honest, in the last 4 years, I would say this thing is still the same. It hasn't really changed. For left-sided and right-sided, we have different guidelines, and that is the way it should be. For left-sided wild type, RAS and RAF wild type, you should use anti-EGFR plus a doublet chemotherapy, both in terms of disease control, overall survival, and for the cytoreduction, if you're looking at a liver metastasis. I think this part is pretty much clear. There is really no doubt or confusion in this. For right-sided wild-type tumors, we know that if you're looking at a metastatic disease where you're primarily looking at your disease control, anti-EGFRs are inferior, so you would go for a bevacizumab in that point of time. For cytoreduction, again, the data for bevacizumab is actually not as good as it would look like. And here we still have randomized trials which have looked at anti-EGFR and they have shown a benefit. So this, by and large, is what I would be following in my clinical practice. For a left-sided, definitely only anti-EGFRs. For a right-sided, if I'm looking at a cytoreduction or a liver metastatectomy later on, I would still be going with an anti-EGFR rather than a bevacizumab. I won't go into detail with each and every trial. The time really doesn't permit me to do that, but this is the take-home message. Now, this is reflected in the NCCN, and we do talk a lot about NCCN and do criticize it correctly many times, but it does give us a useful guideline as well. And the fact that all of these that I have told you, that is the FOLFOX plus BEV, CAPOX plus BEV, FOLFOX with the anti-EGFRs, remember the specialized specification here, use it only for the KRAS, NRAS, BRAF wild type and left-sided only. But in that segment, this remains the standard of care. Yes, we can use a triplet. Yes, you can add the triplet to bevacizumab. There is individual data for that, though it is not as strong as you would like. You're certainly not committing a crime if you do not use the combination. So that for me is the take home. Chemotherapy doublet, bevacizumab, right-sided, yes, for whatever benefit. Left-sided, certainly add the anti-EGFRs. Now, one thing which we do talk about sometimes is whether we should limit ourselves only to these three. Now, the NCCN has still not come accepted or has put it in guidelines that we should do the HER2 and we should do the other so-called pressing type of the mutations that includes the AKT, the mTOR, and a whole bunch of other 6 or 7 mutations. Though there is, I think, increasingly good evidence that anti-EGFRs don't work in that segment as well. So the bottom line for me remains that you have to use a doublet and anti-EGFR for the left-sided. Right-sided, you could go with a bevacizumab, nothing wrong in it. Where the patient is not suitable, then of course you have a whole host of only chemotherapies. And then again, the MSI high segment, you have to use either pembrolizumab, which is preferred in this category, or go with a Nivo-EP combination. So it is fairly simple at this point of time. Why does this assume more importance? is because we know that in the first line, while your median PFS remains 8 to 12, later on it comes down to 4 to 9 months, and in the third line and on, it's only 2 to 4 months. More importantly, look at this bottom statistic. First line, if 100% receive the chemotherapy, second line only 45% would receive, and third line around 20% would receive. And this again is something in clinical practice we are seeing. Yes, you can follow up your patients with a lot of scanning, keep them under observation. You could increase it maybe from 45 to 60%. From 20, you could go up to 30. But in spite of that, a lot of patients actually do not end up getting the second and third line of chemotherapies. So you do need to hit your first line treatment and make sure that your first line treatment gets the maximum benefit. So does this sequence matter? Yes, it does. Now, the trials which are coming up in the next few years will tell us which is an optimal sequence in terms of one versus other. But we do have trials preceding this. We do have some data preceding this. So let me jump straight back to what I started with. Left-sided RAS-RAF wild type CRC, right? This is the area where we know that anti-EGFRs and anti-VEGFs have been tried. The anti-EGFRs seem to have the best evidence in this subgroup. We have two independent meta-analysis, both of them looking at anti-EGFR and anti-VEGF. And again, these are trials which I think I will not get into the details. We have discussed it n number of times. I remember 5-6 years back, the amount of discussions we had on the FIRE and CalGB. The entire ASCO was on fire with these trials that time. So effectively, for us that time, it was a very important question, remains a valid question even now. But for me, this question has been answered pretty much conclusively. If you have a left-sided wild type, the anti-EGFR gives you a hazard ratio of 0.7 according to one meta-analysis. The second meta-analysis again looked at different studies with small numbers. Ultimately, they looked at two things. One group looked at whether you give anti-EGFR followed by anti-VEGF versus the alternative, that is anti-VEGF versus anti-EGFR, and found that the hazard ratio was 0.85, OS hazard ratio was 0.94. Remember, these patients would probably end up getting other medicines down the line and would get anti-EGFR later. So in both of these, there was a significant benefit of this sequencing, that is anti-EGFR, followed by anti-VEGF rather than the reverse sequence. So you have a KRAS BRAF wild type, give your anti-EGFR first line. Do not wait to give it later on. So this is important, and we should test for the KRAS NRAS upfront. So we should not, start off the anti-VEGF and then assume that, okay, let the anti-VEGF go on and then later I'll give anti-EGFR. It's probably inferior. That's my take from this. The second study, also very important, showed that if you just continue your anti-VEGF and never give the anti-EGFR, you're not going to benefit. So you use both, but make sure your sequence remains the correct sequence. That's the important takeaway from these two studies. Moreover, when you look at the various studies, if you have cetuximab plus chemo, followed by Bev plus chemo, followed by a small third line, your median OS in terms of the CalGB study is around 39 months. When you do the other way around, that is give Bev first and then give cetuximab or panitumumab and a third line, it falls to 32.6. Now remember, when these studies came in, we did not really know too much about the MSI and things like that, but having removed that also, this should hold valid for the remaining population. When you look at the overall RAS and left side and right sided, if you give only bevacizumab followed by bevacizumab, you are still going to see only a median OS of around 24 months. So to push it to that 3 years, you need to have the optimal sequencing. The next question, which we often ask, are the anti-EGFR agents the same, the cetuximab and panitumumab? And well, I think again, there are no head-to-head trials between the two anti-EGFRs. And again, while panitumumab is a good drug, cetuximab is a good drug, I don't think there's any doubt that both are good. Probably cetuximab holds a slight edge, mainly because of the sheer volume of data that is there. So when you look at the FIRE3, for example, your cetuximab FOLFIRI showing you a 36.4 months with a hazard ratio of 0.7. This is only left-sided, by the way. Again, the CalGB trial, again showing only left-sided wild type. Again, showing you this 39.3 months where you could use either FOLFOX or FOLFIRI. So this trial, you have two large randomized phase 3 studies and use both FOLFOX or FOLFIRI. What about panitumumab? The panitumumab data is mainly from the peak, and though that has shown a slightly higher overall survival benefit, it's still a phase 2. Numbers are smaller. The p-value is non-significant. When you have this kind of a hazard ratio and a non-significant p-value, it just tells you that probably you needed to have a phase 3 that would have shown you the right figure. Still a good drug. Not saying it's a bad drug, but probably the weight of evidence is slightly higher for the other. Again, when you look at a pooled analysis of the different trials, this is what we are looking at. Left-sided RAS wild type metastatic CRC, panitumumab plus chemotherapy, giving you a median OS of around 33 months. Still a good drug, but again, like I said, probably the weight of evidence seems to suggest that the other anti-GFR might be better. We have discussed this several times that you do have different toxicities of cetuximab and panitumumab. Panitumumab is, of course, fully humanized, so you expect the side effects to be less in terms of the hypersensitivity. The cetuximab is a chimeric, so you have slightly higher side effects that side. However, overall, when you looked at the side effects, cetuximab surprisingly has lower rates of skin toxicity and treatment discontinuation. The numbers are not hugely different, but by and large, it does show that grade 3 for skin reactions are lower with cetuximab. Again, we have to take all this data with a pinch of salt. It's a meta-analysis done later, and definitely it gives you an indication that both are good drugs. That's my takeaway. Again, so if you're looking at the mechanism of action, looking at the indications, looking at all over the other things, somehow you would say the weight of evidence is slightly better with cetuximab, though you would want to, you could probably end up using both the drugs. Mostly, personally speaking, I have used more of cetuximab, and again, it seems to work the way it is supposed to. One important point, you could use cetuximab as a biweekly administration, not necessarily weekly. And really, after these two studies, both the real-time as well as the pooled analysis of multiple number of patients, when you gave it weekly versus 2 weekly and the results were same, hazard ratio of 1.04, a non-inferiority established, less than p-value significant. So I have actually stopped doing mostly weekly. Weekly is not as easy as it sounds. As it is, you are giving a 48-hour infusion. You would prefer the patients to come once in 2 weeks, and it's pretty safe when you do it with the 2-weekly regimen. What about cytoreduction? Again, this is an area where there is a bit of a confusion, and to be honest, not all trials have shown the same quantum of differences. You do have a lot of confusion with regard to the data analysis. By and large, one thing that is sure is if you use cetuximab for a RAS wild type, whether you're using it on the right or the left, you do have a significantly good ORR for the combination as compared to chemotherapy alone. Now, the meta-analysis showed that the overall response rate for cetuximab or panitumumab plus chemotherapy is significantly better in terms of ORR and in terms of PFS. Does this really conclude that it will give an overall survival advantage? Not really, but at least you're having this ORR and you're having a PFS advantage. And in the meta-analysis, at least they did show that the weight of evidence was favoring the combination of cetuximab with the chemotherapy. Is the quantum of benefit same when you're looking for bevacizumab? The answer is not really. The combination does not seem to show the same benefit, though the median OS is higher for the Erbitux and chemo versus bevacizumab and chemotherapy. This is again in patients with right-sided tumors. So the general conclusion that right side means no cetuximab is not really that easy to say. It is slightly more nuanced than that. Again, coming back to the ESMO Pan-Asian guidelines, which agree with the meta-analysis and establish the role of an anti-GFR. Again, when you look at the phase 3 trial, you're having a good ETS that is early tumor shrinkage. The OS is better, and again, it is numerically higher with the cetuximab. What about rechallenging? Can we use rechallenge EGF anti-EGFR? And in third line, you could still go with a doublet with an anti-EGFR or single agent irinotecan with cetuximab, or even an antibody monotherapy. So all of these are included as second and third line, and tells you that you could rechallenge with your cetuximab. Does the same data exist for bevacizumab? Not really. There is data that if you continue bevacizumab beyond progression, there is some advantage. But again, for me, I don't think the final answer has been reached as far as the right side is concerned. If I have a right-sided and RAS wild type, I might still end up using cetuximab in my later lines. That's my conclusion. So clinical data does support the cetuximab rechallenge. You have the phase 2 cricket study, the correct study. Remember, these are, some of them are unselected, some of them are only for wild type. PRS in the second and third lines for around 3.5 to 2 months, it's what we expect. So we could use your cetuximab in a rechallenge as well. Now, ongoing rechallenge studies are there, which are looking at something like this. For example, the FIRE 4, which is looking at Cetux plus FOLFIRI, Cetux plus FOLFIRI followed by Bev. Then at progression, use Bev FOLFOX. Again, at third line, use cetuximab versus physician's choice. So this is going to be an interesting study when it finally turns up. It's a long study. It's an interesting study, and I would be interested in seeing how the liquid biopsy performs here, because that's something that will tell us. So to conclude, left-sided wild type, choose the right sequence, starting with anti-EGFR agents. Whether we should limit ourselves to RAS and BRAF for extended panel, still a matter of debate. I think personally you should do it, but where it is not, the mutations are not seen, anti-EGFR is the way to go. Right-sided, widely metastatic, unresectable CLM, go probably with a bevacizumab. If you're still looking for a resection or a reduction in size, cytoreduction, I don't think we should write off anti-EGFRs yet. You could still do it. There is some difference between the two anti-EGFR. Importantly, you can rechallenge anti-EGFR in the third line. So let's wait for further results to see how the rechallenge will go. So thank you very much, and over to the organizers again.
Thank you so much, Dr. Vamshi. As usual, you gave us the right way to sequence our treatment strategies in metastatic CRC in a very eloquent manner. And with that, we come to the end of the two-day conference of the second changing outcomes in the sphere of GI cancers. Today, we started off with Dr. Bhuvanchuk's moderation with Rahul Sood, Viraj, and Amit as his panelists. And it was a discussion of GI case-based panel discussions focusing on molecular tumor board. And then we had the session of HCC with Dr. Vijay Agarwal and Dr. T. Raja talking about the ASCO abstracts on HCC and systemic second-line treatment option advanced HCC respectively. Then, of course, we had Dr. Deborah Mukherjee, who spoke about how we can use or choose systemic treatments in advanced stage HCC when it's beyond childhood age. Thereafter, Dr. Vineet Talwar spoke about immunotherapy in a combination with chemotherapy as becoming the new standard of care for treatment of first-line advanced biliary tract cancers. Axel Grothi, as always, excelled in discussing about the immune checkpoint inhibitors in CRC, when and how to select. Dr. Bishwade spoke about microbiome in young onset CRCs. Dr. Vamshi finally showed us the right roadmap of ideal drug sequencing in the management of metastatic CRC. Over the last 2 days, yesterday and today, we have been able to cover from esophagus to gastric to liver cancer, pancreas, and colon cancer. I would like to thank all the attendees, delegates, all the faculty members and the panelists, as well as, of course, all the sponsors who were there with us throughout the entire conference. It goes without saying that we need to thank all the 3 organizing committee members, Bharat Vaswani, Anant Ramaswamy, and Viraj, who made sure and who were there with me throughout the entire journey to clearly delineate the topics and the talks to be given to each of the faculty members. Of course, Dr. Naresh Somani has to be thanked because he was the guiding force behind these 2-day seminar. And now I hand over to Tarun for the concluding remarks. Thank you so much, Tarun, for everything.
Thank you. Thank you so much, Dr. Dattatreya sir, for giving this opportunity. As you have already said, I think 2 days have been very engrossing in terms of discussions. Great show under your leadership. So we profusely thanks on behalf of the organizing team, my colleagues Surbi, Pooja, and Aram. It's been a great show. Thank you so much once again. Stay safe, enjoy your dinner, and see you next time. Till then, bye-bye.
Thank you. Thank you so much.
Thank
Bye,
you
everybody.
and good night.